that the availability of good medical care tends to vary with the need for it in the population served, and that this inverse care law operates most completely and more completely where medical care is most exposed to market forces and less so where such exposure is reduced. And it remains as relevant now as it did in 1971, and its importance has very much been brought sharply into focus during the COVID-19 pandemic. And this last year has shown a spotlight on the devastating effects of health inequalities globally and the impact of market forces on healthcare, communities and individuals. So it feels like this conference comes at a crucial time and will reflect on the inverse care law, the origins of the GPs at the Deep End Project and its work, and look at progress in health inequalities and think about what needs to happen next in Scotland. So without further ado, I'm going to introduce you to our first speaker, who is actually the second speaker on the programme. We're just doing a little bit of swapping behind the scenes here. And our first speaker for today is going to be Professor Sir Harry Burns, who needs little introduction in Scotland. He was Chief Medical Officer for Scotland, of course, between 2005 and 2014, and is current Professor of Global Public Health at the University of Strathclyde and President of the British Medical Association. And throughout his career, Sir Harry has been driven by an interest in the science of wellness, of health inequalities, and of the factors that determine how long and how well we live. And the title of his talk today is Health Inequalities, Public Health Matters. Thank you, Sir Harry.
Hi, Harry, do you have the sharing button active? And you just need to unmute yourself up at the top of the bar up at the very top of the screen, and you can unmute yourself there.
Okay. Okay, I hope everyone can hear me and see these slides. Basically, my medical career has taken me to this conclusion. As a surgeon, I was a consultant for about 5 years in the East End of Glasgow, operating on people who were coming in with self-inflicted illness, you know, patients with recurrent acute pancreatitis and so on. You'd say to them, listen, John, if you don't stop drinking, you're going to die. And the response was routine. Yeah, I know I'm going to die. I know that booze is bad for me, but I don't care because life's really rubbish. And the conclusion I reached was, A, they don't need more surgery from me. What they needed was more well-being. And I left and did public health. And as I have gone on, I've become more and more convinced that this is the case. Health inequalities are caused by a lack of well-being, not too much illness. And sometimes as doctors, we forget that because pathology and pathogenesis of illness is often what we focus on rather than creating well-being. And it's an honor to be associated with a Deep End GPs event, because the Deep End GPs are the ones that I first came across that really got this. How do I change the slides here? Yeah. So health inequalities. We sometimes think of Scotland as being the sick man of the UK, if not Europe. But if you look into the history of our life expectancy, this slide shows life expectancy going back 160 years. You can see that Scottish life expectancy throughout most of that time has been at about the European average. You see the impact of the Second World War and the First World War there, but it's only around about the 1950s that we began to decline in life expectancy. And that arrow shows the rate of growth in life expectancy since the 1950s in the most affluent 20% of the population, whereas this shows the rate of growth in life expectancy of the poorest 20% of the population. And you can see that Scotland's relative decline in life expectancy relative to our other 16 Western European neighbours is largely due to a decline in well-being, or a relative decline in well-being, in the poorest sectors of the population. There's nothing inherent in us that makes us unhealthy. And this work was originally, it came from Alistair McGilchrist, who was working in Glasgow University at the time, and he began to question, like me, what was actually driving this widening in health inequalities. And what he did was he took mortality, all-cause mortality in the population in 5-year age bands, drew it like this with Scottish Index of Multiple Deprivation along the bottom, death rates per 100,000 people in the most affluent 20%, down to death rates per 100,000 population in the most deprived 20% for each 5-year age band. And he reduced the data on that slide to a single number by subtracting the best from the worst and dividing by the mean. And you come up with a number here that represents the steepness of the inequality curve, the slope index of inequality. And if you do that across the population, you come up with a graph like this, and it shows an interesting thing. The widest inequalities are in young people. Shoots up in the teenage years, it's at its highest in the 20s, 30s, 40s, and inequality, relative inequality, is declining amongst elderly people. But we think about the common causes of death, the cancers, the heart disease, and so on. They tend to occur in older people, but they're the population where we see the least relative inequality. So his next step was to take individual causes of death. Here's ischemic heart disease, plotted the slope index of inequality for that. And when you plot that, you see heart disease is a relatively low contributor to this great bulge in inequality in death rates in the younger working age people. So what's causing that bulge? Well, it's drugs, alcohol, suicide, accidents, and violence. These are by and large, socially determined causes of disease, whereas heart disease and cancer is up here. So when the Prime Minister says he's going to have a go at obesity by limiting advertising of fatty foods and so on, he's not going to impact very much on the health inequalities. It's down here, socially determined causes of death need a social response. And while I was doing my master's in public health, I came across this term salutogenesis. As I say, doctors know all about pathogenesis, but this was the first time I had heard this word after about 20 years from starting my medical degree. Salus was the Roman goddess of well-being and safety, and the Scandinavian School of Public Health had pulled together this slide, which shows about 25 different theories as to the causes of well-being under this umbrella of salutogenesis. And I'll just mention one or two of them. What most of them, in fact, conclude is that the causes of well-being, wellness occurs in individuals who grow up to be optimistic, who feel they have a sense of control, that they control their own destiny internally. They're not at the whim of external events. They feel they can deal with those external events. They have a sense of purpose and meaning in life. They're confident in their ability to handle what the world throws at them, and that's often due to the fact that they have a supportive network round about them. Supportive family, nurturing family, safe and secure childhood. And one of them, Aaron Antonovsky, particularly struck home with me when I was reading it, when he said, Antonovsky was an American sociologist who spent a lot of his time working in Israel, where he studied the health of adults whose children had been in concentration camps. 2/3 of them were damaged irrevocably by those events, but 1/3 of them had come through them very well. And what he concluded was that the ones who survived and had well-being were ones who had found the social, and before they had gone into the concentration camps, had found the social and physical environment that they grew up in to be comprehensible, manageable, and meaningful. And he concluded that if you didn't have that experience, you would be chronically stressed. Now, of course, this rings a bell with those of us who know Michael Marmot's Whitehall study. This slide shows daytime cortisol levels in higher grade civil servants, the purple lines here, which throughout the day are lower than the cortisol levels in the lower grade civil servants. Why should the higher grade people have lower stress levels? Well, one of the reasons might be this sense of control. If a minister asks a permanent secretary to do something he doesn't fancy doing, what's he do? He just gets someone further down the hierarchy to do it. So the folk at the lower end of the civil service have less control over their day-to-day workload and are more stressed by it. And there are a whole load of examples looking at children in orphanages who have high stress levels, etc. The key thing about this chronic elevation in the stress response is that it, particularly in children, is that it affects brain development. The brain responds to the chronic signaling it's getting of stressors by developing differently from those who grow up in a secure environment, who are not stressed. And the key areas that change structure are the prefrontal cortex, the center of executive decision making, the bit of the brain that allows you to process information and decide how appropriately to respond to that. That does not develop so well in stressed young people. The amygdala, the bit of the brain that lights up when you're emotionally aroused, that becomes more active in stressed young people. So they're more anxious, aggressive, fearful. And the hippocampus does not develop so well, and the hippocampus is important for memory. So children who come from difficult backgrounds are more anxious, aggressive, fearful. They're less well able to learn at school because their memories are less well developed. And when they are fearful and anxious, they respond inappropriately often because their prefrontal cortex isn't developed so well. So these are the kids that get into trouble at school, they get into trouble when they leave school, and their lives begin on a downward spiral that often ends up with them in jail, etc., etc. We didn't just take this experimental work as gospel. We went out into the streets of Glasgow and we got volunteers to have their brains scanned, and I was quite taken with the response of some of them. You know, what, you want to scan my brain? You're going to prove I've got a brain? Can I get a certificate to tell me that? They would say. And you know, these were young people that were constantly told they were useless. They were constantly told they were stupid. They were put down, and they began to believe it. And that hopelessness, that learned hopelessness that grew up with them, determined a lot of the adverse outcome they would experience in later life. We also went on and we measured did psychometric testing. One of the tests we did was a choice reaction time, where you flash up information on a computer and the computer measures the length of time you take to press the correct button. And what this showed is that more affluent Glaswegians, the dark bars here, where it took about 200 milliseconds less time to press the correct button than the more deprived Glaswegians. And if 200 milliseconds doesn't sound very much, if you imagine two cars being driven side by side at 40 miles an hour and a child walks out into the road in front of them, the car being driven by the guy with the turbulent background will take about 2 car lengths longer to stop. Not because he's not paying attention, but because his brain processes the problems more slowly. So we have a situation where we have large swathes of the population who've grown up with poverty and with parental mental illness, with adversity of one sort or another, neglect, abuse, and so on, who develop this learned hopelessness, helplessness, and they begin to move down the social scale. their opportunities become limited. How can you deal with that? Well, the first thing to say is that the brain structure that they live with is not irreversible. I don't have time to go into the science behind it, but Bruce McEwen, the late Bruce McEwen, a colleague from whom I learned a lot of this stuff in America, just before he died, had completed a study that showed that the brain development, the adverse brain development, could be reversed by things like physical activity, mindfulness, mentoring, support. And when you look at how we begin to help people get out of that difficult place they are in, loads of experiments, and I'll just mention 2 or 3 of them, loads of studies have shown how you do that. The Broadway experiment in the City of London looked at 13 rough sleepers with a 4 to 45 year history of rough sleeping. Now that's quite impressive, because the average life expectancy of a rough sleeper wouldn't be much more than 45 years. And they decided that they couldn't get these rough sleepers off the streets by doing what they've always done, you know, sending social work to give them a voucher or whatever. They decided to set up a personalised budget for each of them with £3,000 in it. They offered them personalised support, a mentor, and the mentor's approach was, what matters to you? What do you need? What can I help you get that would make life better for you? And having that conversation built trust, relationships, a sense of control, a sense of self-esteem in that individual that gave them the ability to make choices. One of the first people that she spoke to said, well, could you get me a new pair of spectacles? Because I like to read the papers that folk throw away and I've lost my specs. The most expensive thing anyone asked for was a guy who said the only time in his life he'd ever been happy was as a boy, when his parents would take him to a caravan park in Kent. Could they see if there was a disused caravan there, and he would go and live in it. A year later, 11 of the 13 were in permanent accommodation. A couple of them had sought training and were in jobs. And the average spend out of the 3,000 bank accounts was £800. In reviewing this, that left-wing drag, The Economist, concluded that the most efficient way to spend money on the homeless might be to give it to them. Well, there you go. Stoke-on-Trent did a really interesting study in which they used their data to identify about 1,000 individuals in their area who were living really very turbulent and difficult lives, and they decided to set about doing the what matters to you approach. Build the relationship, help the individual to feel good about themselves, and help them move forward in life. The interesting thing they did was they costed the before and after cost to public services of those individuals. And beforehand, each individual was costing the public services about £100,000 a year, £80,000 in social services, 3.5 in local authority costs. That would be housing officers going in to fix broken windows and kicked in doors and so on. Health service costs, police costs. Afterwards, that £100,000 a year fell to £2,000 a year. Significant reductions in everything, and indeed the criminal justice costs virtually disappeared. The only public service that cost more was education, because more of the children in the houses were going to school more often. And I use this slide to be able to show this to politicians. Actually, invest in people, invest in this what matters to you approach, and it will save you money at the end of the day. We advocate it because it's the right thing to do. It's just and fair and shows compassion for our fellow citizens, but it also saves money. And in fact, these were total recorded crimes that fell significantly over the introduction of that
WhatsApp audio.
That experience. Minimum universal basic income piloted in the US and Canada. In Canada, it reduced domestic violence, better mental health, better hospitalizations down significantly, high school graduations up in New Jersey. And Richard Nixon, in fact, had a bill ready for Congress to make universal basic income a right for every American. However, this was torpedoed by the report that in Seattle, recipients of universal basic income experienced divorces at a huge rate of knots. 50% of them got divorced. And this was said, well, this is what happens when you make women financially independent from their husbands, they leave them. And the bill was pulled. And of course, that was crap. It was fake news. A few years later, someone went back and divorce rate in Seattle did not change. But of course, big business in America did not want money going to the poor. And Evelyn Forget, a Canadian who looked at this, said that universal basic income was ditched because the political right thought it would stop people working and the left didn't trust them to make their own choices. The evidence is support people, help them, don't tell them what to do, and they will make their own choices and they will be for the better. One of the interesting financial aspects of this is that Mark Bellis, who runs the health data system in Wales, has calculated the annual cost attributed to the outcome of in adults whose children had experienced adverse childhood events. The annual cost in Europe is about £581 billion and considerably more in North America. My calculation is that the cost to the NHS in Scotland from children having 2 or more ACEs is £3.9 billion a year. What's not to like? Politicians? You support families, you help them look after their children, and you will see far less pressure on the healthcare system, but you'll all see less pressure on social care, you'll see less pressure on imprisonment of young people who, instead of going to prison, will stick in at school, do well, and pay taxes. Joseph Townsend was a Church of England cleric who was also a medical doctor, who is quoted as saying, "Hunger will tame the fiercest animals, it will teach decency, civility, obedience and subjection. Only hunger which can spur and goad the poor on to labour." And I would suggest that if he were alive today, he'd be working for the Department of Work and Pensions. I also like to mention that as I am a graduate of Glasgow University, Joseph Townsend was a medical graduate of Edinburgh University. So we need to change attitudes in our public services if we are seriously going to tackle this. And the deep end practices are a beacon for this kind of move. Instead of having an existing system that's based on problems, finds solutions, designs services, does things to people rather than with them, run by and for professionals who have outcomes to meet and so on, and they deal with customers who consume services, but by all measures, they have to be efficient and keep their bosses safe. What we need to do is move into a new system where we see that what matters to people is a good life, look for strengths, build support, let solutions emerge, and the whole system is run by a citizen who pulls for support rather than a professional who pushes solutions at them. And doing so, we build strong citizens and healthy communities. And that basically is the public health lesson of many years study into the whole thing that I can come up with. So I'll just stop there. Thanks very much.
Thank you so much, Harry. Inspiring words indeed. And I've written a lot of those things down because I think they will speak to a lot of people who are listening today, particularly the building trust, relationships and a sense of control and thinking about what matters to you. I think for a lot of people who are tuned in and thinking about why they wanted to become GPs, for example, or public health physicians, that really speaks to them and are very interested, particularly over the last year, in how those two specialties can work together even more closely around trying to tackle some of these issues. So maybe that's one for the panel later. But thank you so much for sharing your words of wisdom, Harry. I think we now are going to move on to our next speaker, who was the first speaker on the programme, who is Professor Graham Watt, Emeritus Professor in General Praxis and Primary Care at the University of Glasgow and coordinator of the Deep End project in Scotland from 2009 to 2016, editor of the Deep End International Bulletin, and also a long-time friend and colleague of Julian Tudor Hart, starting with a medical student attachment in 1975. So we're going to pan out a little bit into the kind of origins of the Deep End project, and Graham is going to take us on a journey through the history and the philosophical background of the Deep End project in Scotland, inspired by the work of Julian Tudor Hart. Thank you very much, Graham.
Okay, can you hear me, Carrie?
Yes.
Good. Gosh, what a relief. I'm having a bit of a nightmare in the connection. I remember when we first had a black and white television in the late 1950s, there was a serial called the Royal Canadian Mounted Police, and one episode had a policeman carrying out an appendectomy by phone, instructions from the centre, and of course the phone went dead as he was doing it, and I feel somewhat like that trying to give this talk. But let's see how we get on, and jump in if there's a problem with any of the connections. I'll be getting the slides moved by Mark at the RCPE. So here's slide number 1. Tudor Hart was born in London and lived most of his life in Wales, but his grandparents were a quarter Canadian, a quarter Polish, and 50% Scottish. His maternal grandmother, Annie McNichol from Helensburgh, and her husband, Norman Macbeth, an engineer from Glasgow. So he's not that far away. Next slide. It's about 50 years since publication of his paper on the inverse care law, and it's not an anniversary he would have been keen to celebrate. It was an early publication, his 5th, with over 150 and several books to come, many of which he deemed more important. And the big idea that fueled his life's work was that a general practitioner working on a defined front of the war against misery and disease could improve the health of a local population. And further, he believed that by working together and with their communities, primary care teams in the NHS could sow the seeds of a better society. Next slide. The title Inverse Care Law was catchy, and it drew on Isaac Newton's inverse square law. But while Newton's law had precise and predictable properties, the gravitational pull between two objects varying inversely with the square of the distance between them, the inverse care law was a loose amalgam of several things, none with mathematical properties. Next. Julian was very clear that while medical services were not the main determinant of mortality or morbidity, that was no excuse for the failure to match the greatest need with the highest standards of care. Next. In 1971, with the NHS barely 20 years old, he was concerned about the re-entry of the market into UK healthcare. As night follows day, that's a prescription for inequity and inequality. Asked for how long the NHS would last, Aneurin Bevan replied, for as long as people are prepared to fight for it, implying not one single effort, such as the battle over the 1948 Act, but a sustained campaign of defence, like maintaining maintaining a Dutch dike, keeping the tides of market interest at bay. And looking south, as NHS England steadily seems to be succumbing to market encroachments and privatisation by stealth, would-be defenders of the NHS are being tested as never before. Next. There was another important theme. Notwithstanding universal access free at the point of use, for which the NHS is famous, if the distribution of healthcare resources is not commensurate with need, inequity and inequality will result, as some groups get the benefits of effective needs-based care whilst others don't. Julian argued that this wasn't just about resource distribution. It was also about the preferences of the medical profession, as indicated by the content of medical education, the undervaluing, indeed disparagement of general practice, and the career and geographical choices of doctors. The challenges were cultural as well as political. Next. Next, yeah. Julian was unusual as a commentator on health inequalities, in that unlike most writers on the subject who have little or no connection with policy or practice, he could do something about it in his own community. He worked with the MRC Epidemiology Unit in South Wales, whose community studies had demonstrated the usually asymptomatic nature of very high blood pressure. The VA trial of blood pressure lowering had shown that strokes could be prevented. Echoing Brecht's dictum, "The figures compel us," Julian became the first doctor in the world to measure the blood pressure of all his patients. It was the beginning of 25 years of looking after a whole population, pioneering information systems that measured what he hadn't done, the measurement of omission, so he could identify and address the rule of halves, working with patients initially face-to-face, shifting slowly to side-by-side, employing and empowering his practice team, living and working in the community, staying long enough to make a difference, the difference being that premature mortality was eventually 30% lower than in a similar neighbouring village. He put his big idea into effect, reversing the inverse care law in one of the most deprived communities in South Wales. This story is one of the foundation stones of general practice and mustn't be forgotten. Next. The killer slide. Fast forward 20 years, this slide divides the Scottish population into tenths of just about 500,000 in each group, most affluent on the left, most deprived on the right. Premature mortality in blue and multimorbidity in red increase over 2.5-fold across the spectrum, but funding in black is broadly flat, especially in the more deprived half of the population. 20 years ago, it was possible to measure GP manpower in whole-time equivalents, but the 2003 GP contract removed that information. Amazingly. Total GP funding per patient, as shown in this slide, is a pragmatic alternative, albeit imperfect, measure of GP resource, because of course, not all of it is spent on patient care. Consultation rates in the bottom in green rise a little, about 20%, but with no extra resource. This is only achieved in deprived areas in the bottom right-hand corner by having shorter consultations or working a longer day. Next. Stuart Mercer showed that GP consultations in that right-hand corner were shorter, dealt with more multimorbidity and social complexity, had lower expectations and poorer outcomes, especially for patients with mental health problems, and were associated with higher GP stress. The reality of the inverse care law as experienced by doctors and patients. Next. Turn the slide upside down and you see where we got the idea of a swimming pool and the Deep End logo. Next. With the deep end of a pool, the steep slope of need, the flat line of resource, a sunrise or a sunset, depending on your disposition. Top left, a thistle for Scotland. Down the left-hand side, a spirtle, that's a traditional stirring instrument. The whole thing a flag for rallying under. Next. And now there are similar flags for deep end projects in Ireland, Australia, and 6 English areas, plus possible projects starting in Canada, Denmark, the US, and Belgium. Next. There's been 4 Deep End international bulletins, each with 40 pages of news and views from the various Deep End projects. The 5th will be ready shortly. The projects have given identity, voice, shared activity, shared learning, and policy impact to a previously neglected group of general practitioners, and by proxy, for the patients and communities they serve. Next. What can DPEN GPs do and what can be done to help them? The first step was to listen to what they had to say. At a conference in 2009 involving GPs from practices serving the 100 most deprived communities in Scotland, that's about 10% of all practices. 2/3 of practices were represented. It was the first time they'd ever been convened or consulted. The seating plan was a circle with everyone in the front row. The conference report captured their experience and views. Next. And set the agenda for a series of roundtable discussions on specific topics, all with short and long reports on the DPEN website, the latest addressing general practice in the time of COVID. Next. Some reports have been about austerity, welfare benefits, alcohol pricing, drawing on the experience of practitioners to highlight social issues as they affect patients. Next. But DPEN advocacy has mainly been about healthcare. If healthcare is not at its best where it's needed most, inequalities in health will widen. As healthcare has become more effective, the implications of inequity have become more important. Next. All this gave rise to the End Manifesto. More time for consultations addressing the inverse care law, better use of serial encounters, building local health systems with general practice as the natural hub, better sharing of experience and learning, better support from the centre, stronger leadership at every level, especially ground level. Nothing very startling there. The last point on leadership emphasised by Tudor Hart, who commented, everything depends on leaders at practice level, demanding media attention, gaining public support, and insisting on material resourcing from governments in return for which they can guarantee immensely greater efficiency of care generated by people who know each other. He knew that to achieve change, new alliances would be needed, with politicians and the public to put pressure on the establishment. Next. Of course, not every GP signs up to this. My colleague Rhiannon Babel, now back in the States, interviewed GPs working in deprived areas of Glasgow. All saw their role in clinical consultations. Some saw no further than that, while others tuned in to patients' social situations, viewed the local community as a resource, saw the social and political determinants of poor health being played out in front of them, and wanted to do something about it. Next. Engagement and listening were the first steps, but only a start. Keeping the initiative going required coordination, documentation, continuity, provided in the Scottish project by colleagues in an academic department. With a network of interested practices, we were also ready to take on projects when opportunities arose to show what could be done, because advocacy isn't only what you say, and in inequalities in health, there is a huge volume of things that people say. It's also what you do. Next. Over 10 years, the Scottish project has developed worked examples of extended consultations for selected patients, GP protected time, attached or embedded co-workers, including linked practitioners, social care workers, financial advisors, and alcohol nurses, enhanced multidisciplinary teams, a pioneer scheme for young GPs. To date, only link workers and financial advisors are being rolled out to all DPEN practices. In both cases, after almost 10 years of pioneering work, we've learned that advocacy isn't a short sprint, but a marathon, requiring persistence and perseverance, and not being deterred when the establishment, by which I mean the existing order of power and resource, says no, as it often has. There is a lot of unfinished business. Next. In 2019, we had a conference in Glasgow to celebrate the life and work of Julian Tudor Hart, the progress of the DPEN projects, and the publication of a book, The Exceptional Potential of General Practice, with 55 contributions from 11 countries, 44 of them general practitioners, 50% from Scotland. I think there's no other book like that with such a Scottish input. Next, the idea of the book was that medical students and young and not so young doctors would say, yes, that's what I do. That's what I want to be part of. That's what my career needs to be about. Next. The primary motivation of most deep end GPs isn't to address the abstraction of inequalities in health, but rather to improve patient care, closing the gap between what they're able to do and what they could do with more time and resource. And this is partly about evidence, but it's also about values. I shadowed a GP in Scotland's most deprived general practice, Petra Sambali, observing her day from 7 in the morning to 7 in the evening. I wrote it up in the BJGP. Saw multimorbidity in large measure, and I don't mean the simple counting of conditions, but rather the number, severity, complexity, and continuing nature of health and social problems in families and households. A succession of complicated stories. I saw the importance of prior knowledge, allowing consultations to start at a higher level, and without which much less could be achieved in a short consultation. I saw the importance of empathy and the trust patients placed in a doctor who knew them well and cared what happened to them. I saw no worried well patients, but I saw a worried doctor using her better knowledge to anticipate and try to prevent complications. She was ambitious for what might be achieved, not immediately, but over time. Every patient mattered. Next. In Tales of 1001 Nights, Scheherazade had to invent a new story every day. Her life depended on it. And that's also the task of primary care, helping to create strong patient stories. Every practice is a compendium of stories. But what kind of stories? Who knows? It's a black box. Next. An important part of story building is boosting patients' knowledge, confidence, and agency to take charge. Next. Without which self-care and self-help, self-management are destinations, not starting points. It's a shared journey, in Julian Tudor Hart's words, initially face-to-face, shifting slowly to side by side. Next. Not every patient needs that, but in Scotland, the 10% of patients with 4 or more conditions who account for a half of potentially preventable unplanned hospital admissions certainly do. Next. Patients with multimorbidity are all different. There's no simple case definition, but their needs are the same. Unconditional, personalized, continuity of care from a small team of providers whom they know and trust. Relationships are the silver bullets of general practice and primary care, and not just relationships with patients. Next. The intrinsic strengths of general practice or family medicine are first contact, population coverage, continuity, coordination, flexibility, long-term relationships, and trust. Features that aren't exclusive to general practice, but very few public services have them in such large degree. And that makes general practice the natural hub of local health systems. Next. Of course, hubs go nowhere unless connected via spokes to other services and community resources. And each spoke is a relationship that needs to be built up and looked after. Next. It follows that realizing the exceptional potential of individual general practices requires competence not only in clinical consultations, but also in 2 building programs, neither based on bricks and mortar or fancy architecture, but on relationships. The first, building a compendium of patient narratives over time. The second, building strong local health systems based on general practice hubs. Next. In this respect, The independence of individual general practices is both an asset, providing huge scope for local initiative, enterprise, leadership, but also a liability as a prescription for variation, inefficiency, inequity, and a weak collective voice. The exceptional potential of general practice, its contribution as a coherent system, depends therefore on three types of accountability: upwards to funders, providing quality and value; downwards to patients and local communities, addressing their needs; and sideways to other practices, ironing out inefficiency and inequity. Next. So a third building program is required, strengthening the capacity and collegiality and solidarity of practices via a range of supporting and connecting infrastructure. Next, including resources commensurate with needs, information systems to measure omission and monitor progress, the balance between routine and emergency care, the quality of patient experience or stories, the amount of social capital in local health systems, etc. Educational opportunities to share experience and learning, research and evaluation to show what works, career opportunities to attract and retain committed practitioners. Next. Of course, the building programs I have described are needed everywhere, pro rata based on need, but if the NHS is not at its best where it's needed most inequalities in health will widen. There's four cogent reasons for beginning at the bottom of the slope. Healthcare is not built on a level playing field, it's built on a slope. First, by improving outcomes for individuals and delivering such care for everyone, population health can be improved and inequalities in health narrowed, reversing the inverse care law. Addressing health inequalities is a consequence of such care rather than its starting point. Next. Second, for health service managers, stronger care in the community can prevent, postpone, or lessen crises requiring emergency A&E attendance or hospital admission. Patients can pass through the gateway to emergency services at any time they wish, but when they have access to a primary care team they know and trust, when they're confident in their care arrangements, and when the complications of their conditions have been prevented, they choose not to. The elegance and sophistication of this type of gatekeeping is that there is no gate. Next. Third, for an increasing group of deep end practitioners, this is what they aspire to do. It's the direction they want their careers to take. It's the collegiate culture they want to be part of. Here's the Scottish Deep End Steering Group meeting recently. Lots of young GPs, mostly women. They are the future. They are the beating heart of the project. Next. Finally, and perhaps most important, it's what publicly funded doctors can contribute to the healing of society. The late John Berger, who many know as the author of a book about general practice, The Fortunate Man, also wrote, when reviewing the work of the artist Frida Kahlo, in the dark age in which we are living in the New World Order, I don't need to tell you what that is, the sharing of pain is one of the essential preconditions for a refinding of dignity and hope. Much pain is unshareable, but the will to share pain is shareable. And from that inevitably inadequate sharing comes a resistance. Next. Healthcare can be part of that resistance by excluding exclusions, keeping everyone on board, building three types of relationship. Inclusive healthcare can be a civilizing force in an increasingly dangerous, fragmented, and uncertain world. Thank you.
Graham, thank you so much. That is a wonderful setting of context for the rest of our day and a real rallying call to action as well. I'd like to move seamlessly on to Dr. Katrina Morton, who's our last speaker before we take a short break for a stretch of legs. And Katrina has spent her career as working as a GP on the front line in deprived communities, firstly in inner city Manchester and Nottingham, before moving to Craigmillar Medical Group in Edinburgh 25 years ago now. She attended the first Deep End Steering Group meeting and has been an active member ever since. And for 5 years, Katrina was also chair of the Lothian LMC and the GP subcommittee, and she remains a member of the Scottish GP Committee of the BMA, and also deputy chair of the RCGP in Scotland with responsibility for policy. So a huge amount of hats over many years and lots of wisdom accrued along the way. And she's going to speak to us today from her frontline GP perspective. What does unmet need mean? What does the inverse care law mean at the coalface for patients and practitioners? And what are some of the potential solutions? Thank you, Katrina.
Thank you, Carrie. I'm hoping everybody can see my screen. I'm going to switch off my video. I'll start by saying that RCGP Scotland supports the Deep End work, but not everything I say today necessarily reflects the college's view. I believe that general practice has a role in mitigating health inequalities. With the limited time today, I will give a brief overview of background and evidence and then focus on some examples. But our work depends on the Scottish GP contract, with its emphasis on the expert medical generalist, managing complexity, leading the multidisciplinary team, and the public health role of cluster groups. An important focus for health services aiming to reduce inequalities should be unmet need. For patients, unmet need represents the health issues that we fail to address, and those are greatest for the poorest. For GPs, it is the difference between what we do now and what we could do given the time and resource. I will briefly discuss each of the 4 areas on the slide as examples of how general practice can address unmet need. However, the theme throughout is the strong evidence base for the effectiveness of the primary care generalist, offering long-term relational care. Continuity of care alone brings many benefits, including a reduction in mortality. Chronic diseases, at the bottom of the screen here, or what public health colleagues now call non-communicable diseases, or NCDs, are a big part of the story. 4 NCDs, heart and lung disease, cancer and diabetes, account for more than 80% of worldwide deaths. But underlying those are the top 5 risk factors: smoking, alcohol, diet, physical inactivity, and recently the WHO has added mental health and socioeconomic status, recognizing that they are powerful drivers of ill health. Marmot calls these the causes of health inequality. It is the poverty and marginalization that Sir Harry Burns has just described. We have models of care now which could reduce inequalities. Care plus appointments, which Stuart will discuss further, working alongside patients, developing shared understanding, including of life circumstances and what will help people most. We think of these as new, but most were described by Tudor Hart half a century ago. We've heard from Graham about the steep slopes in mortality and morbidity, seen here in the thumbnail on the bottom right. This Edinburgh Evening News article was written just after the Second Gulf War and reads, "New figures show Iraqi men can expect to live longer than those from Nidri," and quotes the 26 years of difference in life expectancy between the wealthiest and the poorest in Edinburgh. That divide has worsened since, and the life expectancy of men in the vicinity of my practice prior to the pandemic was just 58 years. Compare that with Tanzania, one of the poorest countries in the world, with 3 million orphans, HIV and malaria, with a life expectancy of men is 61. So the inverse care law is alive and well in Scotland. The focus of this slide is on premature mortality. That is the harsh loss of life in the young well before their time. The biggest causes of premature death, particularly in men, relate to mental health, alcohol, drug use and suicide. And again, Sir Harry talked about those. Mental well-being is key to all health, and we will return to that later. The pandemic itself has raised awareness of excess deaths in the poor. those in the most deprived 20% of the Scottish population are twice as likely to die from COVID as those in the least. But that is no different, in fact, from the general mortality gradients pre-pandemic. And these differences will persist and grow with the economic fallout ahead. We still have austerity and UK policies which continue to hammer the poor. The next 5 slides are quick reference ones outlining some of the more specific associations between deprivation and ill health. This study of over 1 million person years was co-authored by Marmot and used both Finnish and London Whitehall 2 data. It reveals both the contributing factors and the time course for the development of various conditions, the size of each circle representing the number of people affected. On the left is young middle age, that's under 50, and what predominates are mental health problems, self-harm, substance misuse, and obesity. When tracked onwards through life, across the screen, those people went on to develop significant mental health medical problems. On the right in the high risk and just in their mid-50s, we see the emergence of severe life-changing conditions, heart failure, cancer, COPD, and dementia. These people are still young, and this is the devastating impact of premature morbidity on their lives. It is also the everyday work of deep end general practice. The same study showed the chance of developing a long-term condition. The first line here, or first column, is socioeconomic status in terms of area deprivation, the second in terms of education. All the dots to the right of each line, of the 2 vertical lines, indicate that poorer people are more likely to develop that condition, and the further to the right, the stronger the odds. There are very few dots to the left. And the Scottish data shows one aspect of that progression. These are the odds ratios for developing cancer, heart disease, and various mental health problems for people with 4 or more adverse childhood experiences. The factors driving adult morbidity and mortality, again, as we heard earlier, are rooted in early life, another area of unmet need. And here is the lived reality behind that data, an account from one of my patients, now in her early 50s. It reflects the strength and determination of people living in poverty, working hard to manage their multimorbidity whilst maintaining their wider lives. She has severe COPD, severe heart disease, and peripheral vascular disease. She has stopped smoking, undertaken pulmonary rehabilitation, exercises daily, and monitors her own oxygen levels. I know that when she phones me with worsening of one of her conditions, that she will already have worked out most of the medical plan to manage that. We aim to work together, side by side. And she manages all that despite what we now know from Stuart Mercer's Scottish data, that multimorbidity is particularly punishing for younger people living in poor neighbourhoods. We could look at any of the risk factors for non-communicable diseases and find poverty at the root, but there is a growing epidemic of obesity and diabetes in Scotland, so I will focus there for a minute. We have amongst the worst food security in Europe. Michael Marmot estimates that the poorest would have to spend almost 3/4 of their income to follow healthy eating guidelines, which are key to diabetes and obesity management. And we must not forget people relying on food banks, which rarely provide fresh fruit and vegetables. There is so much we could do at neighbourhood level to mitigate, an entire talk in itself. And the inverse care law is pervasive, and this data also relates to diabetes care. These are 5 Edinburgh practices which have a similar number of patients. The bars represent outpatient appointments for those with complex or advanced diabetes requiring specialist care. Attendances are in purple and did not attend, or DNAs, in yellow. Craig Miller, my practice, second from the left, has a much younger population than the others, so should have far fewer patients needing referral. Yet the opposite is true, and DNAs exceed others too. These patients missing clinical appointments are then looked after by us as best we can, increasing our workload, but also meaning that they miss out on specialist care. This slide is also about outpatient diabetes care, this time for all of Lothian. From left to right shows worsening diabetes control. Going from top down is the multiple DNA rate. It shows that the worse the diabetes, the less likely the patient is to attend specialist care, and yet we generally have no outpatient strategy or program to address this, and we could mitigate. Text reminders for appointments, which we know work well in general practice, budgeting systems to help those struggling to attend, community-based teams, or best of all, practice-based services. Here, there is no sense of working alongside. So what can we do, and what is the potential role of general practice? General practice provision is itself effective at reducing inequalities. However, we are very, very short of GPs, and we do not have the mechanism to resource care for unmet need. I have talked of hospital DNAs, but we now know that patients missing GP practice appointments are at greater risk too. This is Andrew Williamson's groundbreaking study of 155 Scottish practices. Each of the 4 sloping lines reflects missed appointments. From the lowest line, where none are missed, to a high level of DNAs in blue at the top. The graph represents mortality over time. Those who miss GP appointments, described by Andrea as hidden in plain sight, are far more likely to die. Andrea and her team showed that the excess mortality applied to both mental and physical health measures. Her study preceded the pandemic, and we can only speculate how digital poverty might have made this worse since. An option in general practice would be to look for these missing patients, as we know exactly who they are. In my practice, we are now attempting to more actively follow up those who miss chronic disease appointments, with less focus on others whose conditions are very well controlled. But we cannot do that for the rest of our patients who DNA. We're already working at our limits with the patients that we can see. However, given the resource, we could make a difference, and I will give some examples. Graham has, of course, already mentioned the prime example, Tudor Hart's practice itself, where so much of the reduction in mortality related to chronic disease. Tudor Hart pioneered hypertension care and attributed the impressive improvements in outcome to what we would now call continuity, coverage, and relational care. And we can do this too. Advice and written information won't work for those facing severe life stresses out with their control or who have limited literacy. Digital and online approaches will help some, but widen inequalities for others. Our practice and its patients are benefiting from different approaches: house of care, link worker support, and relationships with local organisations. The focus is on the patient's needs, including emotional ones, what matters to them, and what they feel might make a difference. This is the Thistle Foundation, which is right next door to our surgery, and the poster the result of a session co-producing a care approach. The design team included some of our patients. We would like to be salutogenic too. And a now more specific example. Hepatitis C can cause severe liver problems, including cirrhosis and cancer. 21,000 people in Scotland are estimated to have the infection, and only half know it. There is an association with socioeconomic deprivation and a highly effective treatment. And of course, treatment not only reduces the patient's future risks, but helps break the cycle of transmission too. With short-term additional resource, my GP partner, Mike Gwynn, still runs a hepatitis C clinic in the surgery, providing treatment to those who have not managed to access outpatient care. He identified patients with untreated infection, including those from the other practice in our health centre. A hepatology outreach nurse with a scanner visited the practice, and the local pharmacies provided the specialist drugs. Here are their results. Almost half of these patients had previously been referred to outpatients and not attended, yet Mike successfully treated 21 of the 26 approached. To put this in perspective, just prior to COVID, the entire hospital liver unit covering the whole of Lothian treated just over twice the numbers Mike did in the same time frame. So how did he do it? He says that the GP-based clinic was so successful as he knew or got to know the patients, reached out to them in different ways, and made lots of connections opportunistically when people were seen by others in the practice. He actively tracked them through our appointment system and provided a local, welcoming, familiar clinic, and one which set out to be accepting and address anxiety at every stage. One afternoon, I was duty doctor, seeing a patient as an emergency. Mike recognised my patient's voice in the waiting room and let me know that he had been trying to reach her partner for a final test of pure blood sample. Both had attended Mike's appointments, both were with me, so I was able to bring it up and take the necessary blood. They did not see this as intrusive or inappropriate. They acknowledged that they were not always easy to keep track of and pleased to get the final check done. That is how general practice works. Finally, mental health. This was the main focus for over half our GP consultations pre-pandemic, with escalating levels of need now. COVID has worsened mental health, and yet again, the evidence is that those with lower incomes or no work are suffering more. Specialist services are distanced in multiple ways, and often the most ill will not engage. Mental health is what general practice does. However, what has transformed our practice is having mental health nurses based in our surgery team, possible with our new Scottish GP contract. They phone and see people just as we would, and if a patient presents with depression but has also suffered trauma or is worried about their alcohol use, they can help them with that too. They are generalists, providing relational care with continuity. They can prescribe and refer. They attend our multidisciplinary team meetings where we discuss our most vulnerable families with district nurse and health visitor colleagues. They have time to intervene more and see patients for longer. This relieves GP workload, but also addresses previously unmet need. Our referral rates to specialist mental health services have gone down. The graph shows referrals before and after just our very first mental health nurse started in the practice. That alone reduces unmet need, as our patient DNA rate for those services was 40%. The mental health nurses have also helped the well-being and development of the practice team, who in turn help our patients emotionally, and I'm happy to talk about that further if people have questions. Meanwhile, the death rates in Scotland relating to drug misuse are catastrophic and continue to rise. Our practice supports and prescribes for over 200 drug-dependent people, and they're now largely seen by our 3 mental health nurses, who also offer psychological input and harm reduction treatment. They provide naloxone, BBV testing, and vaccination services. But as we work together, they can alert us if someone is ill or needs help with their physical health. This is another reason why Mike's hepatitis C clinic, based in the practice, was so successful. I will end with this Lancet report, published this month, and whose contributors included the LSE and the Health Foundation. It highlights that workforce planning is siloed and fragmented, with little regard for the overall needs of the health system. The evidence tells us that what reduces health inequalities is expanded primary care provision. These Scottish gradients, second from the left, the steep upward one for consultant numbers, this falling one for GPs, is an inverse medical care law all of its own, and one which underlies so many others. We need to reverse these trends, and not just for reasons of health inequalities. Tudor Hart's book was called A New Kind of Doctor. We now need a new kind of practice and a new kind of health service. Thank you, and I'll now hand back to Carrie.
Thank you so much for that, Katrina. That's a pretty stark slide to end on, an inverse medical workforce law, which is definitely food for thought and maybe one for the panel later. Thank you for sharing those practical examples of what general practice can do, and I think shows the kind of flexible tenacity of general practice that is needed to be able to stick with people throughout thick and thin along their journey. So thank you for that too. We're going to have a short break now. It's 18 minutes past 3, I think, according to my clock. So if we could maybe break for 10 minutes, which is what we had on the programme, which will take us back just before 3:30. I appreciate we're running a little bit behind, but I think it's important that people get a chance just to stretch their legs and get a cup of tea or a glass of water. And we will log back in at 28 minutes past. So we'll see you all soon. Thank you. Hello and welcome back, everyone. We've just been chewing the fat, as it were, backstage, coming up with lots of great ideas for next steps, and it's good to be back for the second half. So I'd like to introduce you first of all to our next speaker for the afternoon, Professor Stuart Mercer, who many of you will know. Stuart is a GP and Professor of Primary Care and Multimorbidity at Edinburgh University, and from 2014 until March of this year, he was also the director of the Scottish School of Primary Care. Stuart has been described as the David Livingstone of general practice research by Graham Watt, exploring the dark forests of the deep end for the last 20 years. And he is going to talk to us about the research evidence for addressing the inverse care law in Scotland. Thank you, Stuart.
Great, thanks. Now, I don't have my slides, Mark. Could you flash that thing up again?
Yes, I can run yours for you, no problem.
Or just if you put the thing up, it disappeared before.
Okay, no problem.
I clicked on it. So I'm not seeing anything. Oh, I'm now the presenter. Okay. But I still don't see my slides.
Okay, no problem. Should I run your slides for you? If you would just call next slide, I'll move that for you.
Probably easier. Okay, still not seeing anything.
Just stand by, it's coming now.
Okay. Sorry, everyone.
Shh.
Okay, it's looking good. That's looking good. Yes. Okay. Great. So thanks. Thanks very much, Carrie, and thanks for asking me to speak. I'll try to stick to time. It's the first time, and probably the last time in my life, that I'll be the warm-up act for Darren McGarvey. So I don't have such high expectations of me. I'm a great fan of Darren's work and his television series, so I'm delighted to be sharing this platform with him. Okay, so I'm going to talk a bit about the research evidence underpinning the inverse care law. Some of that's been touched on by Graham and Katrina. I just want to kind of go into a little bit more detail about it, because I want to make a bit of a point about this type of research. Can I have the next slide, please? And just very briefly to say, a huge thanks to the people on this slide, in particular Graham Watt, who was my boss, my line manager, my mentor for over 20 years when I was in the Glasgow department, initially face to face, eventually I hope side by side. But Graham's been the driving force behind the Deep End, of course. The Deep End GPs, many of whom I've got to know and worked with and feel part of, and that's been a great privilege. Julian himself and of course his wife Mary and son Ben, who I think are with us. Julian was my absolute hero, still is, and a great inspiration. I just want to mention very briefly Bridie Fitzpatrick here, one of the unsung heroes of primary care research in Scotland, and without Bridie's help, many of my projects would never have come to completion. Next slide, please. So just to say, I'm going to focus, I've got 20 minutes, so I'm mainly going to focus on the research I've done. So apologies for that, because there's lots of research that is going on and has been done, is being done but in Scotland and in England. We're delighted to have Bex Fisher here from the Health Foundation on the panel. She's been doing fantastic work with colleagues on the inverse care law in England. Work from deep end academics like David Blaine, Andrea Williamson, Marion McCallum, and all the early year, middle grade and senior researchers in Scotland, far too many to mention. So, I'm going to focus on the stuff I know best, which is what I've done over the years. I started out, and I remain focused on this approach, a holistic approach to care. That's really why I became a doctor. And through medical school and medical training, we get taught all about the tip of the iceberg, the clinical gaze. But of course, to be a good doctor or healthcare professional, particularly a GP, you need to get beneath the surface and into the human story if you're really going to make any difference to someone's life, other than just dishing out pills. Next slide, please. So I started out way back in 1998 when I joined the Glasgow department, when Graham was head of department, thinking about and trying to look at ways, how could we measure some of this human stuff, what people call the human factor. For me, it boiled down to compassion and empathy. And I set about developing a measure of empathy from the patient's point of view, a patient-rated experience measure called the CARE measure. And that was really to try to give us a handle on the patient's views on consultations with GPs and other healthcare professionals. Next slide, please. And we used the CARE measure along with a number of other validated measures in a couple of studies. That was over about a 5 or 6 year period from 2000 onwards. The study on the left was completely done by patient questionnaire. We had patients filling in information about their expectations of the consultation with the GP just beforehand, and also about their experience and outcomes straight after the consultation. And we did this in 26 different practices, 16 of them in deep end areas and 10 of them in affluent areas of the west of Scotland. And we collected more than 3,000 questionnaires. And the reason that Graham and I are the only two authors on this paper is that I was the foot soldier, I was a junior researcher at the time, and I did it basically all myself in terms of collecting the data, printing out the questionnaires, getting them picked up, and so on and so forth. That was a really good learning experience about how difficult it can be and time-consuming to do this sort of research. The second one was a much more well-funded project. We had funding from the Chief Scientist's Office. And in this study, because people were quite critical of patient views back in those days, it's like, well, how can you trust what a patient says? I think nobody would dare say that now. We thought, well, let's compare what patients say with what actually happens in the consultations. So we videoed nearly 700 consultations, about half of them in deep end practices and about half of them in affluent areas. And then we also collected the patient's views as before. And this time we measured the change in outcomes a month later. And this was the largest study of its type in the world then. I think it probably still is now. And it was a whole team of us working on this, but it was a huge amount of work and was only possible because of the cooperation of the patients and the GPs. Next slide, please. So what did we find from these two studies? And some of this has been alluded to, but I'll just go through it again. The patients in the deprived areas, in the deep end practices, compared to patients in the more affluent areas, had, press the button, more problems to discuss, which were more often complex, not surprisingly, because these problems were a mixture of physical problems, mental and social. Press again and again. The consultations were shorter by about a minute. And again, the GPs were perceived as less empathic than GPs in affluent areas. Again, on the objective analysis using these validated ways of analysing patient-centred care, the consultations were less patient-centred. And again, the outcome of the consultation, patients felt less enabled, less able to cope with their illness and look after themselves than in affluent areas. And again, and the outcomes at 1 month after the consultation in terms of symptom progression and overall well-being were much worse in deprived areas than affluent. And again. And we asked GPs to record their stress level on a 10-point scale after every consultation, and we found that the GPs in deprived areas were significantly more stressed than the affluent GPs, affluent areas. And that, in a nutshell, was filling in the swimming pool, if you like. This is really how the inverse care law operates in deprived areas. That was the case back then. I doubt it's changed much now. And I was very happy that Julian sent me one of his lovely postcards, which he drew himself and sort of congratulated on that study. And it's still one of my prized possessions. Next slide, please. The other thing out of this video study, because we had the outcome measures a month after the consultation, we were able to look at the factors that predicted better outcomes, both for symptom improvement and well-being. And what we found out of all the different factors, I mean, many of the patient's factors, such as age and poor health and so on, predicted outcomes. But in terms of the things within the consultation that you could change, if you press it again, please, Mark. The key thing that predicted better outcomes, in fact, it was the only thing that predicted better outcomes, was the patient's perceptions of the GP's empathy using the care measure. And that predicted both patient enablement. We never had high enablement with low empathy. And it also predicted better health outcomes at 1 month in both deprived and affluent areas. So it seems that this relationship, these human factors, are absolutely central in deep end areas as well as affluent. And actually, now there's very interesting new evidence from Cambridge, from Hajira Damba-Miller, who's looked over a 10-year period at care measure at baseline and outcomes at 10 years, and she's actually found a reduction in mortality in people who rate their GPs as empathic. Next slide, please. Then things all changed. About 2009, I managed to get a large grant from the Chief Scientist's Office, a project grant. It was a one-off. They've never repeated these since, but they were, I think, very successful. A number of people got them in Scotland, and I got one to look at multimorbidity in relation to deprivation. And this paper came out of that. It was a big data analysis of multimorbidity across Scotland. Next slide, please. And we published this in the Lancet in 2012. It's probably the simplest paper I've ever done in terms of analysis. Yeah, it's the one that's most highly cited, more than 3,000 citations now. So it does show you what you can do with big data. But what it shows is as people get older, everyone gets some degree of multimorbidity. But in the more deprived areas in dark red, that's the most deprived decile in dark red, compared with the most affluent in dark green, there's a 10 to 15 year gap. So people living in deprived areas develop multimorbidity 10 or 15 years younger than in affluent areas. And of course, this contributes to the inequalities that Sir Harry Burns was talking about. And when I talk about multimorbidity, we included addictions, alcohol misuse, mental health problems, 8 different mental health problems, 32 physical conditions. So it's a broad brush approach. Next slide, please. And why is multimorbidity important? Well, it's not very good for you. It kills you. The more conditions you have, the more likely you're to die. So if you get a lot at a young age, that will lead to higher premature mortality. Again, it gets you into hospital. Graham alluded to this, especially unplanned admissions. So the more conditions you have, the more likely you'll be admitted to hospital, not surprising, but this is vastly increased by deprivation and by mental health problems. And again, it massively reduces quality of life. So the more conditions, the worse your quality of life is. And this is particularly true in deprived areas. So for a given number of chronic long-term conditions, the impact on quality of life is higher in people living in deprived areas than people living in affluent areas. And again, so for all of these things to do with multimorbidity, it's worse in deprived areas compared with affluent. And next slide, please. So to go back to the consultation, which is the thing I kind of started with, we wanted then to say, okay, what happens with multimorbid patients within consultations in deprived and affluent areas? And we looked again at this video data set. And what we found, next slide, please, is that if you look in the affluent areas, Then patients with multimorbidity compared with those without, that's people with one condition or zero long-term conditions. In the affluent areas, the multimorbid patients had consultations which were longer by 40%. The patients perceived the GPs to be more empathic, and the GPs were more patient-centered in those multimorbid consultations than in non-multimorbid. And none of these differences were found in the deep end. So for the multimorbid patients in the deep end, they're kind of treated like everyone else, and that's because there's so many of them, and the GPs are struggling to keep their head above water. And the biggest difference between deep end and non-deep end is in the outcomes of the multimorbid patients. They're the ones who are suffering most in the deep end. Next slide, please. And even at this point, when I would be giving these talks, there would be sometimes a bit of an air of indifference, not by GPs in the deep end, but by other people. I'm not going to name names. So what? We know this, Stuart. You know, deprivation, inverse care law, it's all about the social determinants. This is what you'd expect. You can't change it. So next slide, please. Always like a challenge. So we set about trying to show experimentally if you can reverse the inverse care law in deprived areas with these multimorbid patients who are the deep end of the deep end, can you actually show it make a difference? Next slide. And this led on to the Care Plus study, which I led with Graham and many other colleagues. Next slide. And we developed a whole system approach, as we called it, a complex intervention. At system level, we gave the practices who were in the Care Plus group, we did it as a randomized, cluster randomized control trial. So some practices got this and some didn't. The ones who got it had longer consultations for selected multimorbid patients over the course of a year with continuity. So the same GP or nurse saw that patient for 12 months, and at the first consult, and the consultations were substantially longer than the usual 10 minutes. The GPs then had support meetings that we provided, and we gave them a structure for these consultations that they could use called the care approach, based on an empathic, patient-centered approach. And then we also gave the GPs, the patients, additional self-management support in the way of mindfulness CDs, stress management techniques, and so on, which we gave that to the GPs and they could pass that on to the patients. Next slide. And the first challenge was really, could we actually get practices and patients to take part? This sort of work hadn't really been done. And we recruited 8 practices really very easily. And we recruit each arm of the intervention, recruited 75, 76 patients. We collected baseline measures before we randomized the practices. And then at 6 months, we had follow-up rates, and the follow-up was all patient rated in terms of outcomes. So we had to go to patients and get the questionnaires filled in and so on, of 90% at 6 months and 88% at 12 months. So this is gold standard in terms of a cluster RCT. And it was a huge amount of work on the part of the team and Bridie, but it shows it can be done. Next slide, please. The consultations were longer. They were delivered substantially longer, 35 or 40 minutes for that first consultation. Patients were very satisfied. Next slide. The patients saw the empathy of the GPs as higher, and they felt more enabled. Next slide. And at 6 months in the Care Plus group, quality of life improved a little bit, and it decreased in the control group. Next slide. And at 12 months, all of the outcomes which were around well-being and quality of life shifted in the direction of Care Plus, and a couple of them were highly significant. So we were able to show improvement in well-being and quality of life. Next slide. And I think one of the exciting things for me also was that it was massively cost effective. It cost more money, of course, but it was cost effective, well below what the UK government currently supports through NICE as being a cost effective intervention. Next slide. So, and again, and again, and again, and again. So I'm going to go quickly because I'm running out of time. In a nutshell, we know that the inverse care law works by limiting what practitioners could otherwise do. We turned that on its head in Care Plus, and we found evidence of effectiveness and cost effectiveness. Next slide. But the question in the last minute or so is, hasn't it all changed? We've got all these new reforms, we've got a GP contract in Scotland, and so on and so forth. Next slide. And then press again. And again. And again. And there's a whole host of questions that we need to ask. The deep end, actually, not most deprived patients in Scotland are not in deep end practices, but are scattered elsewhere. We know very little about them. We know very little about the new model of care, how that will affect inequalities. How do we mitigate the effects of the pandemic in deprived areas? How do we retain and rebuild the workforce? So there's a lot more to be done. And most of these things I've listed are not well evidence-based at present. Next slide. I think holistic care needs holistic research. And the sort of research I've shown you requires co-production with GPs and patients. And it's very time consuming and painstaking, and it takes much longer. And funders generally don't recognize that. Next slide. And again. So we need funding to do such research on the English School of Primary Care. I have to get this dig in, I'm afraid. 9 universities just been awarded £32 million from the Department of Health for the next 5 years, building on 20 million in the last 5 years. Big smile for them. Scottish School of Primary Care, 9 universities. We've got £50,000 for the next year. We don't know after that. To be fair, we did have 1.25 million back in 2016, but that ran out. So if Scotland is to keep ahead of the game and compete in much needed research, we need funding to do that. Next slide. Julian's words, as Graham has said, sadly as relevant now as 50 years ago. Next slide. And there's much to do. Thank you. Then you can stop now. Excellent.
So much, Stuart. Again, lots of questions that I'm dying to ask you, as I'm sure lots of our delegates are for the panel. So I'm going to move on now to our next speaker, and very excited to introduce Darren McGarvey, who many of you will of course know. And Darren is a broadcaster and a rapper and Orwell Prize winning author of the hugely influential book Poverty Safari, which I would highly recommend if you've not yet had a chance to read it. I certainly found it pretty life-changing as a GP working in a deep end practice. And Darren talks about the importance of including people and communities in discussions like Stuart has just alluded to, in terms of holistic care, and holistic research needs a holistic approach. And if we want to talk about poverty, then we need to listen to people who live it. And this very much echoes Julian Tudor Hart's description of his experience in the Welsh Valleys when he describes his interactions with the communities he cared for over many years as being initially face-to-face and then eventually side by side, which is a very kind of powerful image. So this community voice needs to be heard when it comes to consulting with communities and those with lived experience when we write policy or when we design services. Otherwise, we end up propagating the inverse care law, where we've got services designed by healthy, usually affluent people, optimally designed for use by healthy, often affluent people. So it gives me great pleasure to introduce Darren. Thank you so much for joining us today. Over to you, Darren.
Thank you very much, Carrie. And thank you everyone who has taken part in the event, either as a delegate or as a panelist. I am aware that we are running a little late. My talk today is on the theme of social connection, and I don't have any slides. I'm not formally qualified in anything, so you can take everything I say with a pinch of salt. But these are observations based on living, working and observing many of the communities that are most acutely impacted by the inverse care law and all of the other inequalities that that is related to. This is also, I'm reading from the manuscript of my second book, so it might be a bit rough in patches. I'm hoping that it won't seem as rough to you as it does to me, but it should hopefully encapsulate some of the themes that have been discussed so far without direct reference to the inverse care law. Okay. It's a gloomy Sunday. I'm on the edge of a beach, gently rocking a pram containing my sleeping baby girl, looking on as my son builds a sandcastle with his mother. Children are playing. All is well in the world. About 20 feet to my left, climbers scale a rock face, aided by professional equipment. The air is cool but pleasant. But we are not really at the beach, nor are we standing by a rock face. We are stood in a shopping mall, which is doing its best to simulate for us the experience of being outside. Nothing here is real. The sand is synthetic, the light unnatural. The air is conditioned. On the concourse, statues of fawns and small birds. In the car park, plastic flowers hang from artificial trees. The potted plants are fake. This environment has been carefully curated to create the illusion of nature, and once glimpsed, it becomes hard to unsee its falseness. Even the overbearing police presence is cardboard. So much of what constitutes human experience today is entirely simulated. We increasingly derive our sense of community from gadgets and contraptions which act as substitutes for genuine human contact. We give ourselves completely to digital applications which interact with us to imitate the properties found in human relationships. At night, we soothe ourselves and our children to sleep with the artificial sounds of nearby conversation or running water. We consume dietary supplements which replace the essential nutrients which come naturally from sunlight, and energy products which promote alertness in the absence of adequate rest. There is clearly a great desire to connect with nature, each other and ourselves, but increasingly this demand, which is central to our well-being, is supplied by synthetic produce or facilitated by technology. This also extends to human relationships that once occurred naturally as a matter of practicality in many communities. The adage that it takes a village to raise a child is rooted in the understanding that we function optimally in close-knit communities where we feel supported, integrated, and useful. Today, society is awash with mentors, life coaches, counsellors, self-help gurus, and influencers to whom we turn in moments of doubt, pain, or crisis. Yet with more means to connect with others than ever before, why do so many still feel so alone? Why do so many people still feel unsafe, insecure, and unfulfilled? And why do we see an explosion in mental health and physical problems which at their root may arise from social isolation? There is no substitute for human touch, a warm embrace, firm eye contact, or a calm, reassuring voice. Each produce the essential hormonal cocktails which allow us to attach to others and our environments, become motivated, and experience gratitude. It follows that the demand for synthetic and technological imitations arises because the authentic alternatives on which they are modelled are in shorter supply than at any time in our history. And in the absence of the essential ingredients necessary for the production of wellness, community cohesion, purpose, and meaning, we reach out for whatever we can get our hands on to quiet the nagging feeling that we are in some way incomplete, oblivious to the tragic reality that the comforts to which we often turn for a momentary reprieve are often the cause of our deep unfulfillments. There is a way out of the simulacrum and into a realer existence, but not everyone can afford the admission price. The less money you have, the less able you are to purchase your way out of the sensory obstacle course, and the more likely your social connections become frayed as a result. Social connection is everything in life. Many of the instincts, cognitive capacities, and emotional responses which ensure our survival early in life are activated by the interactions we have with other people, emerging from attachments we form and beliefs we develop about the world around us. Think of the skin-to-skin contact between a mother and her baby, the sense of security elicited in the child by her loving embrace. Even before birth, we listen from the womb for signs that we are safe, secure, and loved. As we grow, we develop additional attachments beyond our immediate caregivers, mimicking the speech and body language of our peers in nursery school, adopting new interests, attitudes and behaviours which cannot be accounted for by how we are parented. Our sense of independence develops, bringing us into conflicts which, depending on how they are resolved, leads to the formation of strategies and values which subtly shape who we will become. Social connections lend vital context to our experiences, as well as promoting the development of empathy and a growing repertoire of dynamic social skills. Relationships are educational and instructive. Every brush with another human being, no matter how inconsequential, can teach us something useful about ourselves, others around us, and the environments in which we cohabit. Our lives are improved immeasurably by merely interacting with one another. A trip to the gym is often time to unwind mentally, but our physical performance and mental endurance is often improved by training with others. We may nip out for a walk hoping to declutter our minds, but find that a stranger's smile or kindly holding a door for someone is what places us on a surer mental and emotional footing. Someone referring to you by name or remembering something from a previous interaction can elicit a sense of emotional satisfaction, which is extremely palpable but also very difficult to describe. Words of encouragement help us work harder. The local barista remembering how you take your coffee breeds a comforting sense of familiarity. A local cafe owner throwing on an extra portion at no charge because you are visibly tired may energise and inspire you. Every interaction lays the foundation of a natural rapport and trust from which a wider sense of safety, security, and wellness can emerge. But this takes time. The connections we form with other people, whether primary or secondary, are fundamental to our individual success. But more importantly, every connection we have becomes part of a complex overlay of natural and artificial social networks, which will determine, in a general way, the aesthetic, social, cultural, and economic outcomes associated with our communities. I think of the sleepy little hamlets I have visited while promoting my first book. Places like Burnham in Perthshire, famed for a tree so old it was allegedly written about by William Shakespeare. Beautiful tight-knit towns where the community's central focus was not food banks, but on setting up an annual book festival, something no self-respecting town can do without, apparently. I recall the bright red solitary phone box in the corner across the road from the Arts Centre, a thing of beauty, wrapped from top to bottom in white twinkling fairy lights. The hotel doors that were never locked, the front door upon which handwritten instructions on how to enter the premises in the absence of staff was prominently attached. The single off licence in one or two pubs, the locals, many of whom were on first name terms with each other. And I recall the dilemma of being unable to locate a bin to discard my cigarette butt, but due to immaculate conditions of the pavement, the thought of tossing it in the street filled me with acute panic and dread of judgment. In stark contrast, the exterior of the Saracen Head pub in Possil is covered in fagged outs, and the bin in which they should have been discarded was torn from the wall. The local community centre was a relic from the 80s, bearing more of a resemblance to an abandoned factory or a decrepit prison than a welcoming public space. Possil had no central preoccupation. The community was fragmented and aesthetically characterised by a visible, asymmetric disrepair and dereliction. Are people in Burnham just better than people in Possil, or is something deeper going on? In post-industrial communities of the sort often discussed in terms of poverty and deprivation, social connections are under increasing strain. Emotional stress, economic uncertainty, and social insecurity constrains the human ability to form and nurture the social connections so vital to individual prosperity and social cohesion. Then there are the coping strategies to which many turn when they become socially disconnected, the bad habits and lifestyle choices when our well-being is compromised. While providing short-term relief, these coping strategies often become self-insistent, rendering us further isolated in a problem. Parents withdraw from children under the duress of sleep deprivation. Children withdraw from school when they feel inadequate or threatened. Addicts withdraw from society, retreating to the margins. In every case, life's adversities require support to traverse. Invariably, the support comes from other people based on the social connections that are available to us. In communities where social problems are rife, it follows that social connection is all the more important. When elderly people reminisce about the good old days, they aren't being nostalgic about having more money. Materially, they had less. What they are lamenting is the sense of belonging that social connectedness brought to their lives. So connected did they feel that they were comfortable leaving their front doors unlocked or their children with neighbours. Post-industrialisation is often framed in terms of employment. Traditional industries were wound down, creating mass job losses and economic displacement, which contributed to social problems like crime and drug addiction. The malaise that gripped many traditionally working class areas in the 80s was one of a spiritual nature. Idleness and lack of purpose, compounded by economic and cultural anxieties, created feelings of emotional discomfort from which many sought a destructive escape. Prior to the period of deindustrialisation were phases of regeneration which created their own problems. Again, we tend to focus on the issues of housing and public space. High-rise housing became synonymous with crime and drugs, while physical spaces in which communities could congregate, socialise and relate dwindled because town planners placed little value on them. But little is made of the abrupt and deliberate dispersal of individuals and families who had once lived side by side as cornerstones of their respective communities and neighbourhoods. Those characters, not the physical structures in which they lived, gave the community its distinctive shape. The key aspect conspicuously absent from the mainstream post-industrial mythos, illustrated so often by the iconography of demolitions and mine and shipyard closures, is perhaps the most pivotal: the needlessly violent severing of vital social connections forged over decades of ceaseless social, economic and political change that once bound thousands of individuals, families and communities together in tight-knit, resilient groups. Connections laid down over generations that gave individuals and families a sense of belonging, of shared history in which to orientate themselves and guide others. How does a person become socially mobile when their neighbours and environments are constantly changing? And what impact does this individual's social dislocation have on the cohesion of the wider community? Social connections are the mechanisms by which people foster resilience, pass down wisdom, and gather useful information. The wide misconception that the individual is the bulwark of society is undermined by the science of social connection. We acquire language by listening to other people speak. We learn to compromise by sharing resources with others, and we learn how to love by being loved. Where social connections are frayed or severed, individuals, families, and communities suffer because the opportunities for more nurturing forms of behaviour to be modelled and adopted are reduced. This does not mean we do not connect or attach. It means we connect and attach to values, behaviours, attitudes, and beliefs which are not always conducive to well-being, and thus not conducive to social cohesion. In the post-industrial period, as many communities vulnerable to changes in society's economic circumstances have become synonymous with poor educational attainment, unemployment, social immobility, ill health and addiction, the demand for social connection is increasingly supplied by the public, private and third sector with mixed results. Social networks are like naturally occurring Wi-Fi that all humans log on to from the moment we are born. Without these networks, we cannot fully develop. Just as Wi-Fi connections can become undependable, social connections and the relationships and behaviours that arise from them can be equally patchy, depending on the quality of the network. Individuals, families and entire communities may succeed or fail based on the quality of the connections available to them. One aspect of community life that emerges from the complex networks of social connection is that of informal social control. Unlike formal social controls, which involve penalties handed down by authorities, informal social controls are enforced by the community. Without positive, affirming forms of informal social control, vacuums open into which more formal controls like policing or less savoury informal controls like criminality insert themselves. The don't grass mantra found in many deprived communities is a form of informal social control, one that is dictated by a pathological distrust of authority, which is not always groundless. But there exist many other forms. The expectation that one must respect their elders comes with no formal punishment, but remains an expectation most people feel. Think of social connections, networks, and the informal social controls which arise from them as entities which can be positively or negatively charged. In one community, the expectation is that rubbish must be binned, while in the other, the sense that binning rubbish is pointless because the community is run down prevails. In one community, people don't think twice about calling the police, while in the other, just the sight of a police car can plunge some into anxiety. Social connection, networks, and informal social controls are central to a community's capacity to cohere and prosper. They are central to how the community looks and feels, but also central to the community's capacity to fight back in the face of the wider economic injustices which render them deprived. Social networks become toxified by emergent properties which are often attributed to individual choices, but which are symptoms of frayed or severed social connection. Gang violence, obesity, multimorbidity, distrust of authority, fatalistic attitudes to health, education and social mobility, and the overarching belief that nothing will ever change are symptomatic of social injury. It is when you contrast these properties with the relative strength and resilience of more positively charged social networks, characterised by higher levels of trust in others and authority, better educational outcomes, increased levels of resilience, and self and community responsibility, that the multifaceted advantages of affluence, often attributed by the affluent to their own individual choices and capacities, are in fact a byproduct of how well connected and networked they are. The relative individual, household and community wealth across health, education, employment and life expectancy are merely expressions of this deeper social advantage. And I think I'll just leave it there, if that's okay. Thank you very much, and I hope that you found that in some way useful.
Thank you, Darren. Incredibly useful. And I think really chimes with a lot of what the themes for me that have been coming out today around connection and kindness and continuity and interaction and relationships, making the world go round, and how do we create a society that facilitates that and healthcare structures that allow that as well. I'm thinking about the disconnection that's happened over the last 15 months with COVID and the impact that that's had on people, so it feels very pertinent. So thank you very much indeed. I'm going to move on to our final speaker for the afternoon, if that's okay. And I'd like to introduce you all to Dr. Noreen Ahmad, who's head of General Practice Policy Division and Policy Lead for Health Inequalities in Scottish Government. And Noreen has been the driving force behind establishing a dedicated short life working group on health inequalities in primary care, and is committed to ensuring that primary care is supported to help improve health outcomes for our most marginalised and disadvantaged citizens. And Noreen was originally going to be joining us for our panel discussion only, so I want to extend an extra special thank you for stepping in at a reasonably short notice on behalf of our CMO, Dr. Gregor Smith, who had to give his apologies at the end of last week due to workload issues. And we were delighted to see in Gregor's report this year specific reference to health inequalities as a key priority area for the Scottish Government, with specific reference to the work of the Deep End. And Noreen will be speaking to us today about the need to prioritise and accelerate collective action across Scottish Government, across the public sector and beyond, to help ensure that everyone can get the best possible outcomes irrespective of their background. So over to you. Thank you, Noreen.
Thank you, Carrie. Not a small task. And I must say, what a rich set of presentations. I'm very much looking forward to getting to the panel discussion. But good afternoon, everyone. Thank you for having me, first of all. I know that Gregor very much wanted to be here today, given his personal commitment to tackling health inequalities. And I'm delighted to have been asked to step in, given my strong links with the Deep End Group from the days when we set up the Community Links Worker Programme, and of course in subsequent years in my respective roles in primary care. Now, I have a long-standing personal interest in how we can better address inequalities. Being of ethnic minority background, I've supported family members whose first language isn't English navigate the healthcare system, and of course seeing firsthand the impact of poor health outcomes on marginalised communities. My PhD research explored language and cultural barriers to effective communication between doctors and patients, similar to what the study that Stuart described in his early days of his career, and the harmful consequences of poor understanding amongst patients. I know it's no accident that Dr. Julian Tudor Hart and the Inverse Care Law feature in Gregor's first annual report. Gregor asked some key questions in his report on how we might all support tackling inequalities, and I'll return to these later. We know that health outcomes and health inequalities are influenced by the social, economic and environmental determinants of health, the conditions in which we are born, grow, live, work and age. So while sustainable employment, access to education, early childhood development, social inclusion, nutritious food and good quality housing have the greatest impact on health inequalities, there is often a view that your ability as health and care professionals to influence these determinants is limited. I think we can agree that that's not the case. So health inequalities, as we know in Scotland, are already the worst in Western and Central Europe, and the pandemic has both exacerbated existing health inequalities and heightened awareness of the need to protect those at risk. I was struck by figures from the first wave. Of the 753 patients admitted to critical care units across Scotland between 1st of March and 2nd June 2020, a quarter of admissions were people from the most deprived areas, compared with 13% of people from the least deprived areas. Death rates after 30 days were also significantly higher in patients from the most deprived places after accounting for other factors such as age and sex. This highlights the simple truth that being poorer limits your access to healthcare and increases your need for it. This is the inverse care law in action. While I want to focus on the role of primary care and primary care professionals in tackling health inequalities, I'd like to briefly outline the action that the Scottish Government are taking to tackle inequalities. As we emerge from the pandemic, there is an urgent need to do things differently, to build a fairer, healthier society based on the principles of social justice. We need to take inspiration from the work of people like Michael Marmot to see how we can build back fairer. Do something, do more, do better. Scotland has ambitious income-based targets towards the eradication of child poverty set in statute through the Tackling Child Poverty Delivery Plan. We're also taking actions to safeguard the more vulnerable, whether it be on account of their socioeconomic position or belonging to a vulnerable or protected group. In recovering from the pandemic, we need to help people regain control of their lives by placing them at the centre of their care through shared decision-making and adopting a rights-based approach. This exacerbation of mental health issues that Katrina alluded to is a serious concern, which was an issue before the pandemic, but has worsened during lockdown. We've at Speed embarked on a substantial programme of work that the Primary Care and Mental Health Directorates in Scottish Government are jointly leading on. This sees considerable investment going into primary care settings to increase mental health service capacity and capability. A primary care mental health development group is overseeing how the fund will be administered that improves patient pathways both in primary care settings and onward referral into specialist services where appropriate. This will make it easier to access care sooner so that as much as possible people are supported so these issues are prevented from getting worse. It should go without saying, but it should be said and continually repeated that government must embed an equality and human rights approach in everything we do to address structural inequalities. So we plan to further strengthen existing work with partner organisations to ensure that what we do is informed by the voices of people with lived experience. Now let me turn to a few specific examples of the action we are taking in primary care. Primary care is at the heart of the healthcare ecosystem. It's the first and only point of contact for many people with the health services. Further strengthening primary care is essential to developing preventative models of care and moving away from reactive management of patients with long-term conditions. These are the key aspirations of the 2018 GP contract. General practice is uniquely placed to do this. It can support self-management by helping patients to fully understand and manage their holistic needs, promoting a focus on prevention, rehabilitation and independence, delivered by increasingly multidisciplinary teams. It can also ensure that access to general practice services is equitable and that clinical practices are focused at reducing inequalities rather than exacerbating them. That's why for the first time the Scottish Government has set up a primary care health inequalities short life working group to properly focus on the key things that need to be done for primary care to play a more active role in tackling inequalities. Crucially, we've ensured that those most at risk of being excluded from healthcare services are represented on the group. This diverse membership helps ensure we hear first-hand experiences of people and what matters to them most. The group has identified 9 themes to support future action in general practice and extended multidisciplinary teams to mitigate health inequalities. These include amongst them access to a healthcare need, unmet need, and missing communities, as well as mental health. A series of recommendations will be developed with the intention of making a real difference, and SG are committed to implementing these. I can assure you the work of the group has been informed by the raft of evidence and initiatives from the Deep End Group and further afield. For instance, the learning from pioneering SHIP has been critical and will shape approaches to developing a workforce with the right capability and skills. The group will also ensure that inequalities are considered on key work programmes extending beyond primary care. A good example of this is the impact of increasing moves to digital engagement with health services. Close links between GPs and patient welfare and benefits advice is a key approach to tackling health inequalities. That's why we've recently announced that GP practices in some of the most deprived communities will receive over £3 million to fund dedicated welfare rights advisors to address growing mental health concerns caused by money and housing insecurity. In addition, the new government has committed to building on the existing link worker programme to ensure that every GP practice has access to a dedicated mental wellbeing link worker. This will create a network of 1,000 additional staff to support mental health resilience and help direct social prescribing. I like to return to the role of the health and care workforce. Tudor Hart believed passionately in the role of professionals in preventing disease and promoting health. While conversations about health behaviours can be uncomfortable for people and those who care for them, we need to normalise these discussions and conduct them in a sensitive manner so that people feel listened to and adequately supported to make a change. Through my regular discussions with SGPC and the wider profession, I recognise the pressure in GP workload at present, but also the desire of patients to see GPs and the wider practice team in person. GPs are rightly trying to ensure that patients are only seen face-to-face when it is clinically most necessary, with telephone consultation offered where their clinical judgment is that face-to-face is not necessary. We are committed to working with the professions to further explore how we can help to reduce GP workload. Early in the COVID-19 crisis, evidence emerged at UK and internationally that suggested some minority ethnic groups may be disproportionately impacted by COVID, both in terms of immediate adverse health outcomes and in a wider context, including economically. As a response to this, the Scottish Government convened an expert reference group on COVID-19 last June with the remit to advise and propose actions to mitigate the harms felt by minority ethnic people and communities in relation to COVID. As well as implementing the ERG's recommendations, we're about to finalise an 18-month immediate priorities plan to address race inequality during this crucial time. This work is firmly grounded in our racial inequality framework for Scotland. More immediately, we are working proactively with health boards and partners to maximise vaccine uptake, collaborating with community organisations and supporting minority ethnic associations such as BMIS to ensure vaccine information is accessible and culturally appropriate and delivered by trusted voices such as community leaders. We also recognise the importance of improving health data in order to identify and respond effectively to minority ethnic communities. I'd like to finish with a number of points I know Gregor would have raised if he was able to have joined us today. Inequalities in Scotland are entrenched and change can only be achieved if we tackle the wider determinants of health. While government has a key role in this, it cannot achieve meaningful change alone. We all have a vital role in reducing the inequalities we see in our practices every day. If we agree with Tudor Hart, we have a personal responsibility to understand what is going on in the lives of the people we care for. If we do, we will provide care and support that they really value. I'll leave you with the same question CMO asked in his annual report. What will we do to tackle health inequalities in everyday practice? What will we do to ensure more equitable access to the services we provide? How can we help the people we care for by promoting agency and supporting access to the services they need, which often sit beyond healthcare? Thank you.
Thank you very much, Noreen, and good questions to be ending on, which I think segues us nicely into the panel Q&A. So thank you very much. I would like to just remind people how to put questions on Slido. You maybe remember from the beginning, but it already feels like quite a long time ago. So if you've got a question to put to the panel, if you could log on to www.slido.com. And then the password, if you like, is hashtag ICL50, which will take you to the questions that have been coming in throughout the course of the afternoon. And I'm delighted that all our speakers are able to stay on and participate in the panel discussion. I'd also like to introduce you to our our other panel member, Dr. Bex Fisher. Welcome, Bex. Thank you so much for joining us. And Bex is a Senior Policy Fellow at the Health Foundation, where she leads on policy work in primary care at a UK level. And a priority focus for the Foundation is increasing equity in primary care. Bex also works 2 days a week as a GP in an urban area of high deprivation, and so we'll recognise many of the things that are being discussed today as well. So thank you for joining us. So please put your questions on Slido. I've been just kind of trying to scribble things down as we go throughout the course of the afternoon, and there's so much that would be great to cover. We're running a little bit late, and Mark has said it's okay for us to stay on a bit beyond 5. So given that we're running, I think actually only 10 minutes late now, if we stay on till 5:15 for those that are able to do that, that would be fantastic, and it just gives us a bit more time to make the most of the people that we've got here today. We won't manage to get through all the questions, but what we will do is save all the questions, and then we can have a look through them and pick out the themes and evaluate the things that are burning in people's minds for our follow-up event, which we're very much hoping to have to build further on the conversations that we've had from today. So, difficult to know where to start, and it's always a bit of a position of responsibility to pick out questions. But I guess one of the burning ones that's come through in various shapes or forms is around how we resource and enable a workforce that wants to do all the things that it has been describing this afternoon. And Katrina's slide at the end of her talk, I think, was a really useful visual representation of what she termed the inverse medical care law in action, which I think was actually a good way of describing it. Which parts of our medical workforce are growing and which parts are shrinking? If we want to see a tackling of health inequalities, do we not need to see a stronger primary care workforce, and how does that look? And so I guess I would like to ask maybe Bex, first of all, from a kind of UK perspective. There's been a lot of discussion about levelling up, and I wonder whether you feel that we need to level up general practice, and if so, then how do we do that? And then I would like to open it up to the wider panel, if that's okay.
Yeah, thanks, Carrie. I think it's impossible to see how we level up health without levelling up general practice. Certainly south of the border in England, we know that the inverse care law is really alive and kicking. So we've got a big funding disparity between practices in the most and the least affluent areas, about 7% once you adjust for need. And GPs working in the most deprived areas here will be responsible for around 10% more patients on their list. Now, if we add in case complexity and consultation rate, I think probably all of us realise that that is a huge amount of additional workload. So I think it's very, very difficult to see how, unless government address those fundamental inequities in provision of care, you can reduce health inequalities. In fact, and we will again all understand that if you carry on with a basis of inequity, almost any intervention you overlay on that is going to just widen health inequalities more. To come to your workforce point, it's such an important one. I wish I had a great answer, and I don't. Something that we're doing at the Foundation at the moment is looking back at all policies that have attempted to address the inverse care law since 1990 in loads of different domains, including workforce, to see what has worked and what hasn't. Because I think we really have to nail this one. We have to get more workforce into areas of high deprivation, and we have to therefore get people to want to work in those places. There will be lots of folk here, myself included, who really want to work in these areas, but we need to enable more people to feel like that. There are some really interesting things going on looking at how we get more GP trainees into areas of high deprivation, how we enable people to feel more confident about the work we're doing, how we embed a social determinants focus into medical curricula so that it's more the language we speak. But this is, it's a huge area. I wish I had a better answer. If anyone does, if they can send it to my inbox, and I will relay it to the folk who I know are, to be fair to them, thinking about this in Whitehall, because we acknowledge that it's a big problem.
Thank you, Bex. So answers on a postcard to Bex. Thank you. That's a good widening up of the question, as well as giving us some specific examples of what that means on the ground. I wondered, Noreen, if you wanted to comment from the work of the Short Life Working Group or other policies within Scottish Government, because I know that this has been something that's been discussed a lot in terms of COVID recovery, but bigger than that, obviously.
Yeah, no, absolutely. I mean, I think I mentioned some of the work around the need to train and provide the resource to the current workforce in working in deprived areas, and also how do we attract more GPs and the wider multidisciplinary team to work in deprived areas. But I think I'd just like to pick up on the sort of GP contract element as well, and the funding formula around that, just picking up on Beck's point there on how resources are allocated. And we have as a commitment, the phase 2 of the contract, which begins to look at funding flows and how that funding going into practices is utilised to better understand how practices are set up and what proportion of funding is used for income and what proportion is used for workforce recruitment purposes. That work has obviously been paused due to the pandemic, but we're hoping to restart that at some point. But it's an important point. We do need to understand the funding flows to really uncover what the inverse care law looks like in detail in terms of money. And then, thinking about the funding formula, I mean, it is what it is at the moment, and that's agreed between our SGPC partners. But it's certainly something that we would want to look at phase 2 of the contract.
Thank you very much, Noreen. Is there anyone else in the panel that would like to respond briefly to that? Or otherwise, I'll move on to some other questions which are related as well. Katrina.
Thank you. I suppose two things for me. One is just that we need more GPs in general. And we've seen the John Gillis report in Scotland, and I think John Gillis is in the audience, but we can look at the GP journey all the way from school, medical school, postgraduate, and see discrepancies really in specialist and generalist training. So I think recruitment and retention, there are lots and lots of things that we can do. So one part of this is getting that right. I think the other part is this extended team, and Noreen's referred to them already, but there's lots of expanded roles that people could have in the extended team. And just, I've talked about the mental health nurses, but if we look at, say, physiotherapists in practice, we know that people in deprived settings will often have high levels of chronic pain. We feel that a lot of our patients who are drug dependent are really self-treating for chronic emotional pain or chronic physical pain, and there's a huge emphasis now on not treating chronic pain with medication, but rather with other approaches. So there's lots of new roles that are there, but we don't have the GPs to train, to supervise. We don't have the premises, so there's a bigger issue around capacity. And just finally, the Pioneer project, which everybody can find on the Deep End website, led by David Blaine, a Deep End academic, just showed that if you really, what they did was, it was almost like a fellowship program, except it was for GPs early on in their career, could stay in a practice, but free up some of the GP partners in the practice, but also really learn more about how to work in the Deep End and embed themselves in a practice. And what we found was that not only did those, it was very, very successful, not only did those doctors tend to stay in that practice, but GPs in the Pioneer practices who've been thinking of leaving also stayed. So there's lots of strands to this. Thank you.
Thank you very much, Katrina. There's been some questions coming in about sort of new models of care within general practice and extended teams, and I think, we very much see this as working as part of a team is the only way that we can do what we really need to do for our patients. But I think one of the challenges identified in the question coming in was is changing the culture around how traditionally maybe the doctor has been seen as the answer to every issue, when we know, working within a team, that we have other healthcare professionals working within the team who can do things if not better than we can. Certainly our physiotherapist within our practice is way better at doing musculoskeletal diagnosis and management than I am. So how do we start to change the way that people feel about seeing other members of the team and not necessarily the GP, and feel confident around that and be able to support these new models of care? I'm wondering if anybody has any thoughts on that. And if not, we can come back to that one, but I'm just looking for hands up. Katrina.
I think Stuart put a hand up, or was that? Or perhaps not.
I did.
You did, on you go.
Oh, I'm
You
so
go
sorry.
first,
I
Katrina.
couldn't
You go
see it.
ahead.
I do apologise. Sorry, Stuart.
Yeah, I mean, I think the danger about the expansion of the multidisciplinary team, which is an obvious thing to do. It's not like we've never had them. We've had them for 20 odd years, but it's widening. The big danger is that we reproduce the silos of the healthcare system within the health centre. So the key thing for me is that we fragment care and reduce continuity. And as Katrina, I think, said, from the research evidence worldwide, continuity is one of the few things that we know improves long-term outcomes for multimorbid patients. So I think it's all about teamwork and about having the time to get the team functioning well. And I think the GP does have a leadership role still, as the kind of conductor of the orchestra, because it's only the GPs who have got that wide breadth of generalist education. So I don't think we can just give up and say, oh, it's all to do with, you see the physio, then you see the mental health nurse, and then and there is a danger of that happening if GPs continue to be under such high levels of stress. Because the idea that the expansion of the multidisciplinary team will reduce GP workload is an excellent idea. It's relatively untested. So we don't know if, often you open up a motorway, it fills up. So because particularly in deprived areas, high levels of unmet need. So I think it's a lot about teamwork. And actually, I was talking last night at a thing called the Compassion Salon with Michael West, who's spent his life studying organizations, and particularly healthcare. And, and his work is about compassionate leadership. And I think we actually really need that in action within healthcare systems, and particularly within primary care teams as things expand. And one of the key things here is protected time. And the governorship was a good example. You give GPs a little bit of protected time, they can do the things that they weren't able to do. Part of that in governorship was the multidisciplinary team, joint meetings with social workers and so on, and it worked extremely well.
And a key thing about governorship, as John Montgomery often says, is that it's the only health centre in Glasgow that's never had a problem in filling GP vacancies, because the locums that they've been able to employ have been so attracted by the kind of work that they're able to do there that's where they've decided to pitch camp for the next stage of their career.
Yes, so building good teams takes time, because we need to build the relationships within those teams as well. Katrina, did you want to come in there? Because I've got another question that kind of links to that. I wasn't sure if you wanted to come in on that point too.
I think the others have said most of what I was going to say. And I guess the only other thing would be about, we have talked, certainly the Royal College of GPs, about a national conversation about expectations. And I'm aware, having seen some of the medical press, that there seems to be a feeling that people with low levels of need, who are articulate, who have access to systems, are tending to use their GPs more. So it's for me, part of this is getting people there for the right patients, if you like. Thank you.
Thank you, Katrina. I guess a kind of related question that's come in, and Stuart had mentioned this as well, about if we want to achieve holistic care, we need holistic research, and how do we co-produce that with the communities that we care for, which I think I would be really keen to hear from Darren on, because, how do we make sure that the systems that we think we're designing, that are designed to care for people, are actually meeting the needs of what people need. So I'd be interested to hear from Darren. I'd be interested to hear from Stuart and Bex as well, within your roles around what does good research look like, what does co-production look like, how do we make sure that we're listening to the right voices and being flexible according to the needs of our communities. Thanks.
I'll jump in quickly because I've got children piling in the door now, so I might have to go quite abruptly. For me, a pretty obvious example or that you could use to sort of parallel to this is what's going on with the drug death crisis, and the kind of fatalism that has crept in within communities where this drug issue is a problem. That there is no help. There is no help out there, or that the help takes forever. You have public officials who have went online saying there's no evidence that rehab works, and so when the people who are regarded in positions of authorities are sometimes spouting these falsehoods, then that just kind of solidifies that impression. I think it's worth looking, if we're looking for people in vulnerable communities or who have comorbidity to trust us, we have to look at what do they trust, who do they trust. That might not be people in the positions of authority or within traditional institutions like health. We have a recovery community in Scotland, which is all self-funded and self-governed. There are no experts in it. There are no hierarchies in it. It doesn't receive government funding. And a lot of the recent data that's been published, particularly in the United States, shows a person's got as much chance of getting sober sitting in a room with a bunch of recovered alcoholics a few nights a week as they have with an entourage of medical professionals who are only available from 9 till 5. So I think it's sometimes it's about, I know it can be difficult, especially, doctors, experts are rightly revered, they're highly qualified. They've dedicated their lives to public service, and that does command a certain level of respect. But I think sometimes it can be hard also for us to locate humility. That, and you touched on it earlier, you say sometimes you don't have the answer to the problem. And it must be difficult to say, I don't know. I do not know what to do with you. And sometimes that answer can lie in the community itself. Obviously, I'm not talking about people who have complex health needs. But I went to doctors for years presenting with mental health problems, and no one thought to ask how much I was drinking. I was prescribed Valium, I was prescribed antidepressants, and I don't blame doctors for that. I think we know a little better now that a lot of my mental health problems were actually hangovers, and I just didn't understand. I was an alcoholic at the time. I got that answer in the community, in church halls and community centres. And I think that the answer to creating that trust and that rapport might lie there as well.
Yep, thank you, Darren. And I guess just thinking about a very relevant example of that at the moment being COVID-19 vaccination and trust within local communities about that, and we're seeing varying levels of uptake across the country. Thank you so much for joining us. If you need to go, very, very grateful for your contributions today. Just slip out when you need to, but thank you.
Thank you.
Graham, I see you've got your hand up.
Yeah, it's just a few things. I think we recognise the added costs of care in remote and rural areas, the added costs of the tertiary medicine in highly specialist centres, the added costs of teaching, and something for which there is an added cost but is not recognised or resourced is the added cost of research in populations of the type that Stuart Mercer was describing. He shows us that it's possible to do it, and the reason that it's not done is not because it can't be done, it's because it's not well resourced to do. I mentioned the MRC epidemiology unit in South Wales, which used to get 90% response rates. Well, the research establishment now, if you take Biobank, for example, is satisfied with a response rate of 5%. What about the other 95% of the population? And to go back to South Wales, I mean, the other thing about the Tudor Hart experience was that there was a very active research program going on in parallel the whole time. And it took from the MRC epidemiology unit led by Archie Cochrane the experience that the way to do it was to employ local teams of people who were known in their communities, who weren't researchers from far away. And that was the way to generate very high response rates. But it was done in the context that the patients were helping the doctor because the doctor was helping the patients. So there was a kind of a social contract that was going on, which ethical committees now would prevent all of that research would not be allowed now, because it would be seen as being coercive, that the doctor was using his privileged position to coerce patients to take part in research. And I think to some extent, the focus of research ethics on the individual as opposed to the group has taken us in the wrong direction. So there are quite, I think, deep reasons why the issue of engagement in difficult to work populations is a problem. But I think there's no question that, as Stuart pointed out, you need to work with streetwise colleagues. Bridie Fitzpatrick was the quintessential streetwise researcher who knew how people worked and how you engaged with them. And the research empires need to employ more people like that and to be much more locally based in order to generate the kind of work that Stuart was able to do.
Thank you, Graham. Harry.
Yeah, so if the question is how do we build relationships with communities and change the communities, I would suggest that the way to do that is to ask them what they want. Many folk will be familiar with the story of Beacon and Old Hill in Falmouth. It was published, the publication was called A Glass Half Full from memory. And this was a community of about 2,000-3,000 people, where all the men worked in the Falmouth Naval Dockyard until it was closed. And then over the following few years, it became a war zone. Literally, people were firebombing each other's cars and homes and so on. And it was desperately violent and huge amounts of drugs and alcohol and so on. And it was two health visitors that decided enough was enough. And they put letters through about 50 doors. Here are 50 people who I think might be interested in helping us work out what's going to happen. So they arranged a meeting and 5 people turned up. And over the next few years, the place was absolutely transformed. They asked these 5 people, where do we start? And they said, well, this place is a pigsty. You know, it's the houses haven't been painted for years, the gardens are overgrown. So they started making a visible difference. And gradually, the rest of the community said, change is possible. And they piled in. And there were huge, the local chief constable apparently apologized to them for having abandoned them. You wouldn't often get that happening up here, but, you know, they arranged for first aiders to go out on walking around the place with police. So if they found someone lying down drunk and so on, the guy wasn't arrested as a drunken disorderly. He was seen as a health issue and a problem and discussed, and so they transformed that place. And they started off by asking them, and that kind of we need to do more of that.
Thank you, Harry. Bex.
It was just to build on Harry's point, really, which is to reflect. And I think things have changed since I've been involved in research, which isn't terribly long, 10 years perhaps, but from a kind of, what do we really mean by co-production, and what do we really mean by that old phrase, patient and public participation? And is this a box that I tick on my research proposal to say that I have done it, I've asked someone, I've got a care user working with me, or is this something that I really mean? And what is the frame that I'm going to that person with? Is it, can I help you? Or is it, can you help me? And am I really seeking to understand? And am I really listening to hear? And I feel like if we are really seeking to understand, and if we are really listening to hear, we might get further towards meaningful co-production. And by that, I mean really understanding that our communities can teach us rather than the other way around. I think something I've been interested in recently is the example of poverty truth commissions, which some folk on here will be interested in, know about, and others may want to just have a quick Google, just as a model for seeking to engage with communities in a way that tries to take hierarchy out of it. Because I think I would want to acknowledge that as a GP, we are often seen in positions of power, and if we acknowledge the power that we have and seek to share that and share power with, not have power over, maybe that enables us to get, you know, conversations that are more real, and not just a box ticking exercise that I think we probably all would like to see us move on from.
Thank you, Bex. Noreen, and then I've got a couple of questions which come nicely together after that.
Thank you. I was just reflecting on those comments and thinking about the recent report from Derek Feely on the review of adult social care. And what was really striking about that report was that the finance chapter was at the end of it, and actually the patient engagement, people engaging with citizens in a meaningful and constructive way, like Harry said, ask them and they'll tell you, was right at the centre of that report. And I think that is, there's a real political will right now around building on that and ensuring that there's meaningful engagement at policy level. But equally, everyone's responsible for that engagement with our citizens. And Carrie, you'll be aware of Peter Costin and the work that he does around engaging with patients with lived experience, so being at the sharp end of inequalities, bringing them together and providing peer support to each other has been quite powerful, and that voice is being used in the Short Life Working Group. But again, I suppose the question is back to you around practices. I know it comes back to resource and capacity to do that, but that whole concept of community-orientated general practice, how can we move towards that outward-facing role where we ask people what they want and how they want services to be delivered and work in tandem with them? Thank you.
Thank you, Noreen. So I think that kind of links actually to the next two questions that have come in through Slido. And one is from Heather Still, who says, local community plans have shown that a low level of community empowerment is one of the worst aspects of living in a poor area. How can we build on community strengths when there are low levels of trust and little willingness to work proactively with vulnerable communities? So there's something there about it not happening as much as it should, and that making things worse. And then this other question, which I feel is maybe related, which is from Marianne McCallum, who's on the Deep End Steering Group, about how do we support general practice who see their role as beyond the individual care, beyond the care of the individual, looking at those kind of wider sphere type conversations. And because without the additional support and resource required to do that, we're relying on people to kind of go above and beyond, working longer and harder, and or not to choose to work in that way. So how do we make it possible for people to engage meaningfully with the communities that they serve without having to put in a 13 or 14-hour working day instead of a 12 or 13-hour working day? Because I think a lot of practices really want to be able to do that. So I know that there are probably no silver bullet answers to that either, but I'd be really keen to hear the panel's thoughts on how do we make that possible. And some of it is about sharing examples of good practice. I would agree, Noreen. So the work that Peter has done, the videos that he and his group have put on YouTube are really powerful, inspiring examples of good practice, which sometimes make it easier to then go on and replicate if you're tired and stressed and not looking to reinvent the wheel. But I'd be keen to hear from the panel thoughts on how we resource and support general practice teams to do that kind of work. And I'm just going to ask folk to shout out because I can't actually see everyone on my screen, so I don't know whose hands are up.
I'm going to say something, Carrie, if that's okay.
Brilliant, thanks, Stuart.
Well, I think Sir Harry's kind of said a lot about this already, but I think there's an opportunity here for the GP clusters, this new part of the contract. They're still fairly early days, and we don't know how clusters are going to work in different areas. But the whole idea behind them is that they'll meet the needs of the local community better. And, you know, they are getting supported by list analysts and getting data reports and so on. But the overriding feeling, and we did a national survey, as you know, 2018, of GP well-being and workload and so on. And we asked about clusters. And the overriding thing is that they didn't think that it had anything like enough data support. So they needed the right sort of data about that. So I agree with Harry that we need that kind of big data made local. But actually also, I think there's a real value in getting GPs out and about in the community. I mean, that's what Peter does. It's what we did years ago in a RCGP Scotland project called Living Better. And in fact, Craig Miller took part in it, where we were able to give a bit of protected time so that the GPs could go out and meet the local voluntary sector organisations and invite them into the practices. And these meetings were dynamite. They were absolutely fantastic. And GPs who had been working there for 20 years often knew nothing about these folk, because very few GPs who work in deprived areas live in deprived areas, Peter Corson being one exception. So I think there's something, I don't think that takes a lot of protected time, but it takes some. And at the moment, it's not the right time, because I think the GP workforce, like every other part of the NHS, is on its knees. But if the plan of the MDTs freeing up GP time and so on begins to work, then clusters need to be very heterogeneous and actually work locally. And actually, there's no better way than getting out, meeting the voluntary sector, meeting the folk out there, an afternoon a month, you know, and then building from there. And I think that also feeds into this co-production question, which is not just about the research, but about the services. And if you don't get the voice of the, I mean, for research, if you don't engage with the actual patients and the practitioners, your research is never going to fly. It's never going to get done, particularly in high deprivation areas. And folk want to know what difference is it going to make, and does it make any sense to me? So I think the clusters hold promise, but they will need support.
Can I come in? I think that Tudor Hart wrote a paper on the contribution of primary care to undergraduate medical education, and one of the three things it offered was the correction of social ignorance. And I think GPs and doctors in general need to be quite humble in terms of their understanding of how other people live, given that they are by definition a high achieving, well rewarded and anxiety-free group in many respects. I just remember when we borrowed Scott Murray's example of community diagnosis projects in Dunby Dykes for medical students in Glasgow, and they were attached to practices, that one of the host GPs was the young Alan McDevitt and Clyde Bank, who went on to greater things, and he said he'd learned more about his community from these students going about watching and looking and observing for 2 or 3 weeks than he had in 10 years of practice. So for many GPs, the first step in looking outside needs to be listening and watching and learning, rather than assuming that they have a lead role. Most of the good examples that we have of community engagement tend to come from pioneering GPs. Tudor Hart was one, did lots in that area that's not well appreciated. I'm thinking, Bromley by Bow in London, Laura Nielsen and the Hope Medical Practice and these are just the well-known ones. There are lots of examples in Scotland that I don't know about that are not well celebrated and valued. So I think that this isn't something that can be done and changed overnight. The challenge, I think, is to identify positive stories and to value them and to share them, in a sense, to normalize them so that other people feel able to go down that path. And I think over a period of time, you build capacity and solidarity. I don't see, William Blake, his quote, he who would do good to another must do so in minute particulars. The general good is the plea of the hypocrite, the scoundrel, and the flatterer. It's very easy to talk the right language. The challenge is to make a difference, and I think it's important to have a practical path whereby we identify what's good, what works, and how we can spread it. So that gets back to Harry's idea of a learning system where experience is shared. Can I just put one other thing? And I think that the gold standard measure of whether things are working is the random sample of patient experience, the patient story. What is that actually like to have a stroke in Knightswood or Partick or Possil? Because I think if we had that information, we would find that expectations in some areas are very high and in other areas are very low, and what's delivered is very different. And I think that there's a general lack of understanding of what the random sample of patient experience is. And I think that is a very important bit of information that is hidden because it's not brought to light and it's not shared.
Thanks, Graham. I mean, that would echo a lot of the conversations I think that we've had in recent months and years, hasn't it, around moving from pilots that have been evaluated and have been shown to make a difference to something that is shared more widely. I think making it easy to do the right thing by identifying these examples of good practice, by evaluating them and by celebrating them. Absolutely agree, which has been, I think, one of the things that the Deep End has done so well in the last 12 years. And I know that there's been also a lot of interest in how do we grow a workforce that meets the needs of our populations? How do we widen participation to medical school? How do we cover health inequalities more effectively in an undergraduate and a postgraduate curriculum? How do we get more exposure to general practice so that we have people who are, you know, having their social ignorance corrected, if you like, and more humble in terms of their understanding of what people's lives are like? So
there's a very important aspect of rollout. You know, we've got it for link workers and financial advisors, and so it's important to have the worked example. It's important to have the political decision to put resources in that direction. It's important for the new link workers to have a support system whereby they know what they're supposed to be doing and sharing experience. But there also is a parallel need for supporting the practices who are being asked to work in a new way. The idea that suddenly everyone is going to deliver what Parkhead has delivered with financial advisors is crazy, in the same way that giving a practice a link worker doesn't mean to say they're all going to be like Peter Costin's practice. We know that when you roll these things out, there'll be some practices that take to it like a duck to water. Some will take longer, and some will take a very long time because they're very confused and perhaps resistant to the idea of it in the beginning. So I think that this idea of a learning system, I think, is really important in terms of supporting practices to work in new ways, establishing, because practices don't like to be outliers. So the challenge is to establish norms, new norms that encourage people to go in a particular direction. And it can't be done simply by rhetoric and well-imagined policies. It has to be supported on the ground by relationships in which people share experience and views.
Absolutely.
Carrie, if I could just quickly come in. Yes, I think the link workers, we always tend to think about linking with patients, but I think it's also linking with practices and learning about our communities, and there's huge potential there. And just very, I completely support what the others have said, but just very briefly, I think there has been some moves elsewhere in the NHS, not really in Scotland, to have a digital approach to general practice. And actually, we've all missed seeing our patients as much as, we've had to necessarily reduce our contact with our patients. That's been inevitable. But part of seeing our patients is actually learning about them and learning about our community and being able to respond to their needs better. So just to put in a plea for that. Thank you.
Thanks, Katrina. I wondered if digital exclusion might come up. I would be surprised if it didn't come up, because I think that's something that we've all been acutely aware of in the last 15 months. Is it worsening health inequalities and widening the gap for people who really struggle to use the technology, don't have access to it, don't have access to the private space needed to have the conversation, don't have English as a first language, etc. It has been pretty difficult, I think, for a lot of people. So a lot of thought needed on how we mitigate that moving forward. A couple of questions have come in around continuity of care. That's been, it's something that we hold and value very highly as practitioners, and we know of course that continuity of care reduces morbidity and reduces mortality, but feels particularly important for people who get sicker earlier, live more of their lives in poorer health, have maybe a greater need for relationships of trust and empathy and enablement. And so a couple of questions have come in around whether there is equitable access to continuity across the country, or whether COVID has made that worse, or whether there needs to be provision in the contract to prevent erosion of continuity, specifically by practices being taken over by large practices, so kind of multi practices within Scotland, which I know is still reasonably rare, and is much more common down south. But just concerns around what that does in terms of fragmentation of care, particularly for people who are vulnerable. So I just wondered if anybody had any thoughts on that easy topic as we come to the end of our panel time. Thanks. Stuart and then Bex.
Yeah, just briefly. I mean, I think we know continuity is very important. I mean, it's in a way it's the heart of general practice, the basis on which the relationships form over time. We're probably with a very part-time workforce. I don't think it's achievable now or in the future to provide personal continuity of care to every patient on the list. And actually, probably not every person needs it. I do think it has to be prioritized for people who need it most, and that's probably people with complex multimorbidity. I think people with mental health problems. That makes it harder in the deep end because you've got more of those patients, of course. And that, in a way, makes an argument for preferential funding of practices working in deep end areas. I mean, there's possible ways around it. If you can't always see the same person, you can have a kind of buddy system where maybe 2 GPs will see, you know, it's one of 2 GPs that they'll see. I mean, many practices try to do that. It's often quite difficult to actually operationalize it, particularly if somebody feels they need to be seen quickly. But I do think it's a huge issue, and I think the large super practices that are developing in England, often through the private sector, buying up practices, I think it's a disaster for continuity and for the things that will help the sickest people. I think it might work okay for the worried well or people with minor illnesses, but I don't think it's a recipe for success.
Thanks. Thank you, Stuart.
Thanks, Carrie. I was just going to reflect a little bit of what is happening down south, I think. One is, so Stuart, I would share your concerns about large super practices, but actually quite separate from the privatisation of general practice is the expansion of primary care networks, or rather the implementation of primary care networks in England. So this idea that we are now working as groups of practices delivering care to neighbourhoods of populations, and all of the additional staff, which were of course partly a policy solution to the lack of workforce in general practice, are being shared across primary care networks. So there would be a risk within practice of dilution of continuity of care, but it's not just within practice, it's now right across a network. So we at the Foundation are really interested in what will happen to continuity of care with the implementation of primary care networks, and we funded a team in Manchester, Kath Checkland's team, to do a longitudinal study of that. I think, you know, it's something I am really worried about. The other thing that I'm worried about, just to come back to that first question on workforce and additional roles in general practice, which of course isn't just happening south of the border, is how does recruitment and retention of those roles play out in areas of higher deprivation? The early evidence we have from England suggests that networks in more deprived areas are less able to recruit. So we're going to see a widening of inequality in access as a result of that. And also, are we going to be able to, back to that question of how we support the people coming into those additional roles, do we have the headspace, do we have the time to support those people, to embed them in practice in the way that we need? I think you're quite right, Stuart, there will inevitably be in it a kind of micro team continuity model that needs to evolve around some of our patients. But the impact, I don't know where the balance is here between the need for an expanded workforce in primary care. We clearly need more doctors, but we've been trying for a long time. That's very hard. That needs to carry on. It's not happening. We expand the rest of the workforce. How do we deal with the continuity issue? And how do we segment the population? I guess, to use a bit of a jargony term, but how do we work out who really needs it and how to do it for those who need it the most?
Thank you, Bex. Indeed. Katrina, and then I've got a final quick fire question round, if that's okay.
One of the things we've talked about in our practice is following the NUCA model. So this was a model from Southeast Alaska, and our lead mental health nurse actually went to Alaska to learn about it. And it's very much a healthcare model developed by the community, where they looked at their own needs and their own problems and came up with their own solutions. And continuity is part of that, as is case management. And that was to do with identifying people who may have multimorbidity, may have mental health problems, may be particularly vulnerable, may be terminally ill, and they would have essentially a key worker, a caseworker, if you like, within the practice. And it wasn't necessarily the doctor. So it might be a lead receptionist. In our own practice, we've trained our receptionists to be care coordinators. It might be a district nurse, and they are key to continuity. And people may just be in that system for a while they need it, and then come out of it once they're better or things have resolved a little. So there are models that are suited to deprived areas, but it just needs a lot of work to set up and maintain. So it may be that we can't offer continuity to all, and we know that patients value continuity differently. It's more valued by I think women and people from deprived areas. If I remember right, Stuart's nodding there, he probably knows. So some people will put access in front of continuity, and we know that too. So it's also getting that balance right. Thank you.
Thank you, Katrina. So it's 5:10. We've just got a few minutes left, and I'd like to just quickly say thank you to everyone as well. So I was thinking it would be very disappointing to think that in 25 years' time we would be having a conference about 75 years of the inverse care law. So if you had one wish or one idea that you would like to see brought forward to reverse that trend, I wonder what it might be, just as a kind of a thought for us to take home at the end of today. And I wonder if I could start with Graham. I'll go in order of speakers, and it would have been Graham coming in first, but for our tech issues. Oh, you're on mute, Graham.
Thank you. I would pick a test of whether we can actually change things, not necessarily the most important thing. But there was Stuart contrasting government support for primary care research in Scotland and England. And it's a gross discrepancy, and it's a huge explanation for why it's difficult to make progress in terms of providing evidence. So, and of course, the reason for that is because there are very entrenched establishments of specialist research who have a more powerful call on research. So that's an example of how the challenge is to wrest resource and possibility from the establishment, because unless we do have examples of challenging the establishment, by which I mean the existing order of power and resource, then we will be here in 25 years' time. You know, unless the establishment shifts in some ways, and that's just one example of what we need to do. The balance of specialists and generalist professionals is another challenge. If we don't address them, then the establishment will, which is the existing order of things, may well prevail.
Thank you, Graham. Harry.
It's easy for me. What we need is an improvement science approach to this. When Derek Feely was chief exec of Scottish Government, he brought in Jason Leach, and we started to learn from the Institute for Healthcare Improvement. We reduced patient mortality in Scottish hospitals by an astonishing amount. We've improved well-being in babies and children, reducing infant mortality and so on. And there is enough really good knowledge as to what works, but what we have encountered is that it's happening in pockets. And we create an improvement science collaborative in which we share the learning. We set down what do we want to change, by how much, by when, what are the drivers of change. And I'm just thinking, very shortly, Jason Leach is going to have nothing else to do, so we might as well get him back into the improvement business and make it happen. and collect the data. And I've been speaking to Roger Halliday, the government's chief statistician, about collecting data on this, and he's very positive about it. And what stimulates politicians more than telling them that if they invest a bit of money up front, it will save them a shed load further downstream? Almost $4 billion a year spent in the health service alone dealing with the consequences of chaotic families and difficult life circumstances. And the GPs, particularly the GPN GPs, have shown that they can make a difference in that area. So I would wish for an improvement, collaborative approach to be set up ASAP. Thank you.
Thanks, Harry. Katrina.
Thank you. I guess my last slide was called A New Kind of Practice, Meeting Unmet Need, and I defined it as a deep end practice which was designed, evidence-based, with defined resources and evaluated outcomes, and then mentioned things about generalist care, mental health, clinicians, link workers, longer appointments, care plus appointments would be ideal, and locality-based public health. So for me, a new kind of practice, and perhaps with an enhanced service to support it, but very managed so that we know how well it works, how we set it up, and what outcomes we're looking for. Thank you.
Thank you, Katrina. And Stuart.
Well, you probably expect me to say we need more funding for research, and of course we do. But the bigger picture, I mean, I think I agree with what everyone said, but at the bottom line, we need the political will, sustained political will to support primary care in the way it's needed across the board, but also particularly in deprived areas. It's not a level playing field. And that requires transfer of funding or additional funding. We can't pretend we can do all of this without extra money. And the idea that we can increase the GP share or the primary care share of the budget, you know, from 7% back up to 11%, and that's the answer. I mean, that's just that's, you know, that's only takes us to where we were, and the future has to be much higher than that. I mean, I think back to the CARE report, you know, whatever 20 years ago. We're you know, I'm not saying we haven't made progress. So it's political will, and I think a lot does come down to funding and reallocation of redistribution of resources.
Thank you, Stuart. I think Darren has had to leave us, so I'm going to go to Noreen. I don't know how politically neutral you're allowed to be, but what would your wish be?
Well, I think my wish is quite complicated, but also in a way simple. It's how do we address the implementation gap? Because you can have the political will, you can have the funding, and I take the point that you know, there needs to be more in that, and you can, you know, you really have the support and backing of our politicians, but the implementation gap is where we're falling down. How do we address that? How do we get it out right on the ground? So again, citizen voice in all of this, the human-based right approach has to be threaded through everything we do. Thank you.
Thank you, Noreen. And Bex.
Thanks, Carrie. Thanks everyone for having me. So I would love the implementation route, but I'm a real pragmatist, and I don't see how we solve this problem unless we get equity at the heart of it and proportionate universalism. I think the improvement science, implementation science has to be put on an equitable playing field, not a level one. So fundamentally, I think we need to work out how you properly create a funding formula that adjusts for need, both and undermet need. And then, and this is the magic one, I really wish I could solve it. What are the political levers and the levers within our own profession that get that funding formula implemented so that we get resource, funding and workforce in proportion with need, not equally, but equitably? That's my wish.
Thanks, Bex. Good wishes. Sounds like another conference coming up. So I would like to just take the opportunity to thank everybody, all our speakers from today. So Graham Watt, Harry Burns, Katrina Morton, Stuart Mercer, Darren McGarvey, Noreen Ahmad and Bex Fisher for joining us on the panel. I'd like to give a big thank you to our organisers, as always, These events are very much a team effort, and there's been a huge amount being played out behind the scenes. So a special thanks to Dr. Lindsay Crawford, GP and clinical lecturer in Glasgow University, who has led us on this venture today, putting together what I hope has been as amazing an event for you all as it has been for me to chair, supported by fellow Deependers Maria Duffy, Marianne McCallum, Stuart Mercer and David Blaine. And also thanks to Leanne Brown from RCGP Scotland for her project support, and to Mark, Pentler and Bill for their invaluable tech support during the day today, which is always challenging. So thank you to both of you. And last but not least, a big thank you to everyone who has joined us today, all the people that have logged in. I know that life is very busy and there are lots of competing priorities, so it's great to see so many people who have logged in today to join us. And I guess we've heard lots of things today, lots of food for thought to take away. I particularly enjoyed those last few reflections from the panel in terms of what do we need to see moving forward. I guess we've heard that the inverse care law is very much alive and well 50 years after it was first described, despite the NHS being in its 73rd year, and how do we try and change the direction of travel. We've heard about the importance of having a public health approach, maybe working alongside general practice as key partners in population health. We've heard about the importance of a team activity when it comes to addressing health inequalities, and not just team activity within primary healthcare teams who need time to build these new models of working and understand each other's roles and remits and support, but also team working along with our patients, and what does meaningful community engagement look like and how do we achieve that. And we've heard a lot about how the solutions lie in supporting systems that invest in relationships and continuity and trust and empowerment. So we still have a long way to go to translate the evidence and the practical solutions into policy and action. But I do believe that there is the desire to do that in Scotland, and that we need to work together hard to achieve that and address that implementation gap, as Noreen has mentioned. And a reminder, I guess, for all of us at many points today, that if the NHS is not at its best where it's needed the most, then health inequalities will worsen. So thank you very much, everybody. We hope to have a follow-up event at some point later on in the year. So do keep an eye on our Twitter feed in terms of when and where that will be. We will feed in all the themes and the questions that have been raised today, particularly the ones that we've not been able to answer through the panel. And we'll feed that into what the next conference feels and looks like. As you log out today, there'll be a little prompt that comes up just asking for a very brief evaluation of how you found today, what's been useful. That very much helps us to inform future events. So grateful if you've got a few minutes to fill that in too. So thank you very much, everybody, and enjoy the rest of your week. Thank you.